lot of work in the periphery, and they are maintaining and even doing a better job than what we could do in any of the other places. They have been very instrumental and they have been service oriented as well, trying to give effective or essential newborn care and the pediatric care at a very, very affordable and cost effective way, and doing a lot of service for our people of Karnataka. We are very, very proud that both of them are our office bearer and both of them are young and taken up the responsibility in a very big way. Thank you very much for your service for the people of Karnataka. So today we have two speakers, Dr. Amaresh Patil from Gangavati, and he'll be talking on kangaroo mother care, and we have Dr. Chaitali. She'll be talking on common neonatal procedures. Dr. Amaresh, you will be speaking first, and then Chaitali will take over.
Sure, sir.
Or anyway, I am seeing Dr. Amaresh slide here. Is it okay, Dr. Chaitali?
Yes, sir. Let him start, sir.
Okay. So, on behalf of NNF Karnataka, our president, vice president, and our joint secretaries, and all the executive board members of NNF of the Karnataka office, and on behalf of NNF Karnataka members, we would like to give a warm welcome for our webinar series. Welcome, Dr. Amaresh.
Thank you.
So, I request Dr. Amaresh Patil to start the session, and I request you to kindly give a brief introduction about the work you are doing at your place, because this will be an inspiration for people who are aspiring or who are listening, the postgraduates or who are listening across India. It will be an inspiration for all of them that how beautifully you can do work and give service to the society, at the same time look after yourself as well in a very nice way. Please introduce yourself. Please tell about your work you are doing, and then please start the webinar. Over to you, Dr. Amaresh.
Thank you, sir. Thank you for your kind words. I'm honored to be part of this wonderful webinar series. Thanks to NNF Karnataka and NNF India for this wonderful opportunity. I would like to thank personally each and every office members of this wonderful family. I am Dr. Amaresh Patil. I am based at Gangavati, which is nearby Hampi, birthplace of Lord Anjaneya. At the outset, I would like to offer my honors or my kind amanas to my teachers, Dr. Nirmala Kesri Madam, Dr. M.L. Kulkarni sir, Dr. C.R. Bhanamut sir, Dr. Suresh Babu sir, and Dr. Guru Prasad sir, because of whom what I am today.
One second, Amaresh. Amaresh, kindly unmute yourself and continue the session.
Sir, am I audible? Prashant, sir,
yes, you are audible. Try to make full screen, slideshow mode.
Sir, is it visible now? I made it full screen.
One second. Yeah, it has come now. Yeah.
Okay. Thank you, Prashant Gowda sir, for those wonderful words. I would like to thank NNF Karnataka, NNF India, and each and every member of this wonderful family for giving this wonderful opportunity to be part of this wonderful webinar series. I am Dr. Amaresh Patil. I'm a pediatrician and a part-time neonatologist based at Gangavati, which is nearby Hampi, 10 kilometers away from Hampi, and I'm proud to be placed at this part of the country where Lord Anjaneya was born. At the outset, I would like to offer my namanas to the great teachers because of whom I am what I am today. Late Dr. Nirmala Kesri Madam, Dr. Kulkarni sir, Dr. Bhanapurmat sir, Dr. Suresh Babu sir, and Dr. Guru Prasad sir. These teachers have taught us to be a human first, a doctor next, and always to see the betterment of the babies, newborn care. We are both to the we both to these all wonderful teachers, and I would also like to thank each and every member of this webinar series and each and every person who are part of my life, because of whom I have learned a bit. Every person has made a small impact because of whom I'm what I am today. I come from a small place called Gangavati. This part is famous for rice, fields, and off late, everyone I guess knows Mr. Pranesh, Gangavati Beachy. This person is from this small place. This place is situated near Hampi, 10 kilometers away from Hampi. And this is my small hospital, and this is my level 2 NICU, as you all can see. We provide care to the surrounding villages and this Gangavati Taluk. This is a 16 bed NICU where we provide level 2 care services. We provide care of preterms, care of newborns. We provide ventilator services, and we provide therapeutic hypothermia also. All these services have been possible because of the support of all the local pediatricians and members of IMF family of Gangavati and my wonderful family of IAP Vijayanagar. Without their support, this would not have been possible. I would also like to thank my wife, Dr. Archana Patil, who is also a pediatrician, who is also part of this thing. Coming to the topic, why do we need KMC, or why do we need to worry about babies, in fact? As we all know, 1/5 of the live births occurring all over the world. Out of this, 1/5 occur in India. And unfortunately, India accounts for 1/4 of these neonatal deaths. Of these neonatal deaths, most of these occur in the middle Indian states like Rajasthan, Madhya Pradesh, Odisha, which account more than 30% of this NMR. The southern states, Kerala and Tamil Nadu, are well off, quite well off, with less than 10%. As of the latest census, the neonatal mortality rate stands at 28 per 1,000 live births. Of these NMR deaths occurring every year, that is 2.7 million deaths occurring each year, 35% of them are born prematurely. This is very unfortunate. And these neonatal deaths account to more than 44% of the under 5 deaths. We could see that preterms account for more than 35% of these neonatal deaths in India, which are preventable.
Amaresh, kindly unmute. There was disturbance, that's why we are muted. Kindly unmute, yeah, and continue the session.
Sorry, because once this presentation opens up in the screen, I am not able to see my own video and whether I'm muted or not. Kindly bear with me. Yeah, as I was saying, preterm births account for up to 35% of the neonatal deaths occurring each and every year. These preterm deaths can be preventable, and we as pediatricians and neonatologists can make a big impact and save many more precious lives. What are the major interventions which can save these preterm babies or preterm births? There are 10 to 11 strategic theories which can work and prevent these deaths and save as much as 80,000 and mother as well as child lives. One most of the like the points which are helpful in preventing these deaths are promotion of breastfeeding. Breastfeeding is the best feeding. There's no other thing. Hand washing with the soap, therapeutic feeding, antenatal corticosteroids, water connection in the home, and KMC, that is kangaroo mother care. The other being labor and delivery management, PMT, prevention of mother to child transmission of diseases, and case management of new infection, oral antibiotics, and appropriate complementary feeding. Kangaroo mother care, as we all know, when properly practiced and implemented, can prevent approximately 18% of these neonatal deaths. All these interventions together can save almost 90% of the neonatal lives. That is, they can prevent more than 3.5 billion babies being not able to see the first birthday, which can be prevented by these wonderful interventions. The most important intervention which can be done and which we are going to see further is kangaroo mother care, which accounts for more than 18% of these wonderful interventions. The other being with antenatal corticosteroids. Whenever there's a preterm level which has been anticipated, if there's an antenatal corticosteroids which has been given 2 doses or 4 doses apart, along with kangaroo mother care, if implemented in a proper way, can almost together save 40% of these neonatal deaths. And these are not major interventions, which can be, these interventions can be practiced even at a small village, and even can be practiced by even a small trained ASHA worker, and even a small person can make a big impact and can save many small babies together. When this antenatal corticosteroids along with KMC, if the labor is properly managed, we can save another 18% of the babies. When there's a severe sepsis, if it is properly managed at a proper center, another 13% can be saved. Breastfeeding, with next month gonna be a World Breastfeeding Week. Breastfeeding, no amount of what we say, it's the best, not only nutritionally, but environmentally. As we can see the dread of coronavirus, we can see much on this breastfeeding. This year theme is breastfeeding, help to save the planet. So by promoting breastfeeding, we can save the climate changes, we can reduce the global carbon emissions, gas emissions, and thereby reduce the climate change. So with all these interventions, we can all, by 2025, we can almost save around like more than 2 lakh children with all these interventions. Many number of children as well as their mothers can be saved. So where did this kangaroo mother care? We all know kangaroo. We all know why is kangaroo national animal of Australia. But how does this kangaroo mother care? I guess we have all seen this video, but just I felt this. It's a right time to see this small video. So let's see how this small jelly bean get transferred into. So with this, we can see how the mother touch can transform a small jelly bean into a almost 50 to 60 kg weighing kangaroo. So mother is next to God. That's what we call Taiye Devur in Kannada. A mother touch can transform a small, tiny preterm into a wonderful baby. So that's where kangaroo mother care plays an important role. So when did this start, kangaroo mother care? Today being Guru Purnima, we must remember this wonderful personality, Dr. Edgar Ray, who, along with his workers in 1978 in Bogota, Colombia, started this as an alternative to the traditional incubator care for the care of very low preterm babies as well as low birth weight babies, and termed this method as kangaroo mother care. So this method started in 1978 and has spread to all parts of the world, teaching us going back to the human touch care. That's all I need to say. Since then, there has not only been increasing evidence of providing a safe and effective care. This has also been practiced as a standard care for the preterms and very low birth weight babies. So we must be thankful to this wonderful person. So how do we define kangaroo mother care? I would also like to say that whatever I'm going to talk, or this is mostly of my experience in the past 7 years and bit of research here and there. So any mistakes, kindly let me know. So kangaroo mother care is also defined as early, prolonged, and continuous skin-to-skin contact between the mother and her low birth weight infant or preterm, which can occur both the hospital as well as after discharge, with exclusive and frequent breastfeeding. So continuous and prolonged skin-to-skin contact is an essential part. So the components of KMC care are mainly three: kangaroo position, kangaroo feeding policy, and kangaroo discharge. Kangaroo position, the components, as I mentioned, these three parts. The kangaroo position is nothing but a continuous skin-to-skin contact between the mother and the baby, or the caregiver and the baby. The kangaroo feeding policy is exclusively breastfeeding policy, which is the most required policy, I feel. And the discharge policy is early discharge and continuation of the kangaroo mother care at home. Even after the baby is discharged, the baby needs to be given continuous KMC care at home. So what are the advantages of this kangaroo mother care? Once the baby comes out prematurely out of the uterus or out of the body, this method of treatment provides wonderful care. Also, it simulates the in vitro environment, and it facilitates the physiological as well as psychological stability of the preterm baby. It is the most holistic form of developmentally supportive care, which provides multimodal stimulation.
Hello, can you unmute?
I request all the participants to kindly mute. Amar, kindly unmute yourself.
Sir, are you able to hear me? Prashant sir.
Yes,
We can hear you. We can hear you. Continue.
Yeah. Sorry, because once I'm muted, I'm not able to see because my whole presentation occurs on the whole screen. So I request Dr. Prashant Gowda sir, whenever he mutes all the participants, to let me know.
Yeah,
so as
sure.
I was saying, okay, thank you, sir. So kangaroo mother care is the most holistic form of developmental supportive care. It provides multimodal stimulation. It stimulates all the six senses of the preterm baby, in the right way. This we need to understand. This is a more human touch and human care, which not only involves the doctor, but also involves the mother who has given birth to the baby and all other caregivers. So we all see, we all want, everything in this world is stands mainly on the benefits. What are we going to get of this wonderful treatment? It not only benefits the baby, it benefits the mother, it benefits the society, it benefits the world also. That's by reducing the cost on the family, it reduces the stress on the family. It by reducing the number of stays in the hospital, it reduces the burden on the current bill as well as the society, as well as the being an increased number of survival of preterm babies, thereby help benefits the society or the country itself. So let us see what are the benefits. Benefits, we first will discuss the short-term benefits or in the benefits in the immediate neonatal period. With this human method or human kangaroo method care, since most of the, when compared to, there's a Cochrane review or meta analysis, where when compared to the standard conventional care versus kangaroo mother care, at 40 to 41 weeks of post-menstrual age, the survival rates is more or comparable more than the conventional care of management of a preterm baby. With baby in continuous touch with the mother, there is reduced risk of hypothermia in these babies. When the baby gets to know that the baby is next to its own mother, there will be the heart rate and oxygenation status of these babies are well maintained. So there's a physiological stability of these parameters. And with reduced handling of these new preterm babies, there is a decreased incidence of nosocomial sepsis. Since all the senses have been stimulated in a proper way and being with next to the mother all the times, when there is a small, there have been studies which show that there will be decreased pain in these babies, pain sensation in these babies. So this can also as soother for these, whenever there's any procedure or any IV line to be secured. Babies who are given KMC respond more, have experienced less pain compared to the babies who have not received KMC. Sleep organization, there are studies which have shown that there is decreased REM sleep. The deep sleep cycles are well organized with increased synapses. The sleep is well organized in these preterm babies who receive KMC for a longer duration. Since most of these kangaroo mother babies, cared babies, receive exclusive breastfeeding and receive continuous care by their mothers as well as the caregivers, the growth is comparable to a normal born baby. And last but not the least, it improves breastfeeding because of the continuous bonding with the mother and the baby, because of the whenever the mother feeds, whenever the baby requires, and because of the stimulation, increased stimulation, there's increased breastfeeding rates in these babies. With these benefits in the neonate or the babies, we can also see the benefits in mother also. This small intervention can be benefitable to most people, like not only the baby, mother, as I mentioned before, to the society also. In the mother, because she being involved in this care of the baby, it helps us to know what is going on, what all is going around. And since she's being involved in the care of her own baby, it increases her confidence levels. And she is also personally satisfied because she can see the baby day to day and she can be with the baby at most of the times. Since the baby is always with the mother, it improves the bonding between the mother and as well as the baby, which this bond can last for lifetime, which is most important, which is where we Indians stand apart from compared to others, where we worship our own mothers. The bond between the mother and the baby will increase with this wonderful kangaroo mother care method. Since mother is being involved, she feels empowered, she feels confident because she is being involved and she can take her own decisions. With the baby next to her and sucking whenever requires, the demand is more, so the supply and production is more of. So there will be increased milk production. so decreased need of formula feeds or top feeds. Since these babies are stimulated and monitored and given care not only by the caregivers but also with the mother, these can be discharged as early as possible compared to the babies who are not received KMC. This method can not only reduces stress in the baby but also reduces stress in the mother also. Since she is almost involved with the baby, of late this depression, which is being more rampant in nuclear families as well as in most of the families staying in metros, this wonderful method, bonding of mother and the baby, kangaroo mother care, touch to skin contact of the baby, reduces postpartum depression in mothers. These mothers are mostly single working mothers. This thing which need to emphasize in most commonly in metros, and being depression being more rampant and being most commonly ignored, this wonderful method reduces this incidence of postpartum depression. We have seen the benefits in immediate neonatal period. We have seen the benefits in the mother. The benefits not only stop then, it continues to have benefits in early infancy as well as childhood. These babies who have received KMC grow normally. They would achieve the same amount of growth as they would have achieved in the intrauterine environment. Since most of the senses are stimulated in a proper way and in a right way and in a sequential way, the neurodevelopment occurs is normal or comparatively the most normally born babies. These babies, because of increased bondage with the mother and increased stimulation of all the senses, not only tactile, but gustatory, olfactory, auditory, and all vestibular, almost all the senses have been stimulated, because of which there will be increased synaptic growth, and which in turn lead to increased intellectual quotient or IQ. The babies who have received KMC are able to perform proper functions, and they are more organized physiologically as well as psychologically. And because of the bondage, there will be increased better parent and infant interaction, and there will be decreased. And there's again a Lancet newborn series studies which quote that the KMC reduces almost neonatal mortality by 51%. Neonatal sepsis or nosocomial sepsis by 47% and hypothermia by 77%. A simple intervention reducing such a wonderful, I would like to say that this is one of the wonderful interventions which have been discovered and which needs to be implemented on a larger scale. Breastfeeding and KMC are most commonly required and implemented and propagated in our country, especially in this peripheries where there's ignorance which is in unmeasurable quantity. So these are 20 preterms who are now almost 1.5 years old, I guess. So who all should receive KMC? Any baby who weighs less than 2,500 grams or 2.5 kg can receive KMC. We can divide them categorically into less than 1,200 gram or 1,200 to 1,800 gram or more than 1,800 to 2,500 grams. More babies who are born less than 1,200 gram have more other problems which need to be addressed, like respiratory distress syndrome or necrotizing enterocolitis or neonatal sepsis, which are bound to cause serious morbidity as well as mortality, which need to be addressed first. Once they are stabilized and they are off ventilator, they can be given KMC, but with proper nursing staff around, even ventilated babies as well as babies on CPAP can be given for KMC for a shorter durations. Our unit, we usually give once the baby is stabilized, to be frank. But higher centers like Dr. Suman Rao's St. John's Institute and other institutes, they practice, and our parent institute, we practice in, that is Bapuji Institute. We used to practice KMC even when the baby was on CPAP. So in babies weighing 1,200 to 18 grams, most of these babies, once they, with 1 or 2 days of oxygen or other treatment, they would settle and they can be given the KMC can be started as early as possible. And 1800, 200, 2500 grammar babies, they're usually stable and they can be initiated immediately after birth. Once initiated, it can be continued till the baby weighs or till the baby decides. So this is the same that. So who can give KMC? Kangaroo mother care. Kangaroo mother care. Does it mean only mother can give the care? I don't think so. This is a wonderful unit which we have at Government Subdivisional Hospital, Gangavati. I would like to remember the wonderful work done by Dr. Suman Rao and our team of St. John's and Karnataka Health Promotion Trust and Government of India. The Koppal district was selected for the KMC implementation. This was a wonderful work which has been done by that team along with our minute participation, because of which we are seeing benefits today. And I guess this will be continued. So who can give KMC? Mothers. This is our unit baby. Father. So we all know KFC, a kangaroo for the care. So father can give. Ideally, it should be the mother, but whenever the mother is not able because of any illness or if she has any other work, father can be seen. This is one of the babies which was cared in the own home. This baby weighed around 1,600 grams. This baby was admitted in our the private hospital, Dr. Matisar's hospital, and discharged with the KMC. This baby was on the papers also. This baby is now around 1.5 years, doing well. Or it can be both mother and father, as in this we can see both twins being given by both mother and father. Or this grandmother. This is a wonderful lady, kangaroo mother care. I would like to share a small story of this Hussein Amma. That baby is baby of Hussein Amma. This mother, it is a female baby born to Gravida 3 baby, Gravida 3 mother. It was a female baby and born prematurely, weighing around 1.4 kgs. The mother was not ready to take care of this baby. She didn't want to feed the baby. We tried her. We told her to care for that. We had given the baby to feed also. We had started the KMC in mother also. But whenever we used to give KMC, the baby was used to have fallen saturation levels. We used to see that baby used to have cyanosis and used to have low saturation levels. Well, when we observed carefully, we could see that the mother was almost squeezing the neck of the baby in this big baby. So because she had suffering from postnatal depression and she didn't want to have this child, she didn't want to take care of this child. So the mother was sent back to hospital and for treatment. Her mother Hussein Amma came forward. Grandmother Hussein Amma came forward. She was taking part of this care of this baby. This baby is almost now 1 year old to this July 8th, I guess, doing well. So this is one more wonderful stories. We have many stories of this wonderful. These are the twins. No, so only single, not only preterm babies who are only single. These preterms can be also twins. Most of the twins are born prematurely, so they can also be given with proper training and proper support. This is additional benefit. What we can see here, it also not only improves the bonding between the mother and the baby, but also increases the bonding between the two siblings or the two twins or the twins. We can see this was a wonderful photo. I know there was no cap, but we had given KMC, but this was not done. But those babies had put it on across. So wonderful scene. And this triplets, they had made to the WHO book and also have been published in Lancet. This is one of the wonderful story with the results of KMC study, which have been done in Koppal district. These triplets were cared in our district hospital, KMC, Koppal district hospital. These triplets are now doing fine. Sir, am I audible? Prashant sir?
Yeah, yeah, you are audible. Go ahead, go ahead. You are audible, very clearly audible.
So these are the triplets who are now almost 2 years old. So how long to give? It can be initially we start in our unit, we start whenever the baby is not stable, we start with 1 hour of KMC initially start. Once the baby is stable, we slowly increase. It can be of short duration for 4 hours daily, or once they are stabilized, we continue to 5 to 8 hours. Or some babies who are stable but only require feed and the proper care, we give till 12 hours of the day also. Continuous 1 or 2 babies we do have given. This has to be documented for more on 2 consecutive days or prior to discharge. So when to initiate? The most important part is the baby has to be stable. Once they are stable, a short KMC sessions can be initiated. Even as I mentioned before, even if they are receiving IV fluids or oxygen therapy or a CPAP with proper supervision, they can be started on KMC under trained personal supervision. That is the most important part. Equipments, not much. This doesn't require any bulk order. Whatever is there with the mother or at home, the proper clothing for the mother, that is what they wear. Supporting binder. A binder can be a small shawl or a sari itself or a towel. The clothing for the baby, you should have a proper cap to prevent hypothermia, gloves and mittens. A shirt, ideally, which can be openable at the front. This is a requirement equipments. I guess this doesn't require any major funding from any major institutes, but a major willpower to implement this small intervention. Eligibility criteria, mother, I guess if all the mothers will always be willing to be part of this wonderful initiative because they have given birth, it's their own baby. Just a moral boost will make them willing to give this wonderful care. General health, if most of what we see in our part of world is like our part of country, most of these mothers are undernourished, malnourished. They would have around 18 or 19 or 17 years of age. They'll be so we ask them to eat properly, and I encourage them to take all kind of diets. Another part is since most of these people come from a lower socioeconomic strata, the hygiene also is important because most of them do not have more proper personal hygiene, so they are more prone to again infections. So we advise them to take proper hygiene practices. We ask them to take bath regularly, and the most important part is consoling the family or teaching the family to be supportive to the mother and as well as the community. So this is the same bag which I told before. Preparation of the baby, we need to propon, as I mentioned before, the cap, gloves, mittens, as well as the shirt which can be opened at the front. So what should the mother wear or any caregiver wear? Anything, whatever she wears daily can be worn. There's no requirement which can look according to local cultural traditions, whatever fits her, whatever has good aeration, loose fitting shirts, shawl can be worn or sari can be worn. We ask them, ideally we ask all the mothers to wear sari and come to the unit. So what do we need to do for this implementation? We need to teach them, once we know who all can give and how long to give, we need to know how to give. That's the most important part. So we need to teach the KMC positioning to the mother as well as the other caregivers. They should be taught about breastfeeding. We should allay all their fears, whatever the mother has. And we should also help, encourage the mother to have some amount of physical exercise and also help, ask her to be mentally relaxed. We also stimulate the massage of the baby whenever the baby is given for care. And we should also need to foster, the most important part is foster mother support groups, that is ASHA workers or other groups, and have to have and also need to have whether meetings, educational meetings or monthly meetings. So KMC positioning, this is a wonderful slide where we can see that the baby has to be placed between the mother breast with the head turned to one side, so that the mother, it also prevents if the head turned to one side, prevents the aspiration. Also the mother will be able to have a gaze with the baby, look eye into eye contact. The legs have to be in the frog leg position. Baby's abdomen should be touching ideally mother's abdomen, and the baby's bottom being supported by the mother's other arm. This can be done. Also, we can use binder, which can be tied at the neck as well as at the abdomen, or a shawl can be used, or a sari can be also be used. This is the most important part. And this is what this same thing. If the baby's head has to be placed in the between the mother's breast, slightly extended in the head in a frog position. Baby's abdomen should be at the mother's epigastrium, and it should be supported at the bottom. Can KMC be given only in a sitting position? No, it can be given during sleep. It can be during resting time. It can be given during walking also. While during giving sleep or while resting, ideally the mother should be in a reclining or a semi-recumbent position, or any bed which can be adjustable head and where it can be elevated, or several pillows can be placed on the bed, or a chair, easy reclining chair can be used. Whenever the mother is asleep, if we can tie a small bandi or a sari, mother can go to sleep also. This is the same grandmother where she was being used. This is a baby right now who are receiving KMC in our unit. So we not only use KMCs in preterm babies. One more thing, what I would like to, what we have seen is any drowsy babies who are like parentally asphyxiated, like stage 2 or stage 3 HI babies who are like passed to the convulsive phase and were now on breast NG tube feeds, but still are drowsy. We encourage the mothers to give KMC to those babies also. And once these babies have received, if they are in binder, we can be removed. While removing out of the binder, we need to support the neck as well as the bottom also needs to be supported and slowly can be removed. If the mother knows all this, we just need to monitor and teach her small steps. So with this position, the most important position is breastfeeding. I would like to remember our great teacher, Dr. C.R. Banapurmat sir, who has always thought that's the best feeding in the world and nothing can match it. So all the KMC babies, if they are more than 1400 grams, we can directly put on them to the breast, or any babies who are way less than 1400 grams, we can put them to empty breast. One can express the breast and then put on to just help them non-nutritive sucking. Or the breastfed can be expressed in a palada or a cup and can be given by a spoon or palada feeding. Most important part, we need to allay the fears of the mother. We need to tell her each and every step. Be next to her in all the initial days. Tell her, and we should emphasize the proper position and skin to skin contact. If properly taught and monitored and implemented, she herself can become a teacher or akka to the other next coming patients, where she can help in monitoring those babies also, and she can teach the further newcomers also. So once these mothers are giving KMC, we can ask them to walk, sit, relax, or we can ask them to involve in recreational or educational activities. Yes, there was only one photo. Okay, sorry. So we can ask these mothers to be relaxed. We had some chaukabara. We just ask them to play whenever they feel bored. We had some TVs in our KMCs. Whenever they are board, we put some education bit on the TVs and they would look upon. Whenever the baby is on is put onto the mother's body, or the KMC is being practiced, it prevents apnea. Since most of the sense organs are being stimulated, it stimulates the neural development, proper development in a proper way and a sequential way. That is the most important part. Those babies who are not receiving KMC, because of the increased stimulus of the auditory and visual stimulus, the neural synapses can be synaptogenesis can be impaired and can have a poor neurodevelopmental outcome in terms in resulting in cerebral palsy or lower IQ. Whereas with proper KMC position, these senses are stimulated in a sequential way, and this helps in proper synapses and thereby proper neurodevelopment and lesser incidences of cerebral palsy and normal or increased IQ levels, which is all what we want. Lastly, we need to foster support groups, mainly the ASHAs. We need to be thankful to those warriors. They are not only the coronavirus, they are the persons who are in primary contact with these mothers as well as the family. So telling them and giving them moral support will help in the growth of these groups. This is our KMC unit to the left, and with support group, the ASHA worker going to the house and telling the mother what needs to be done and what needs not to be done also. Once the baby is stable and is gaining weight almost 20 to 30 grams per day, and mother is confident after looking after the baby, we can shift the baby to the ward. Discharge criteria: when the baby is well with no evidence of any infection, feeding well, exclusive breastfeeding, gaining weight adequately 20 to 30 grams per day, and maintaining proper temperature. And if the mother is confident and we are sure that she is able to turn up for follow-up, we can discharge the baby. Discontinuation of KMC, it's the baby who decides when to stop and till when it requires KMC. Most of the times it's the baby. Once the baby is gains adequate weight, it starts to be uncomfortable.
Can you unmute? Hello. Yeah, please unmute.
Sorry. Thank you.
Yeah.
So we usually stop the KMC by whenever the baby weighs around 2.5 kgs, or before only if the baby is crying excessively, if he is fussy, if he pulls out the limbs out and he is not able to keep on the. Usually the mother comes and so we ask them to stop. And mother can give KMC even after taking bath and even during cold nights also. All that is required to implement this wonderful intervention, Kangaroo Mother Care, is proper training of nurses, pediatricians, and other staff who are involved in the taking care of this mother as well as the baby. Educational material, we had wonderful material being supplied to us by St. John's team. And furniture, nothing much. We require small chairs, not much of, we can see all these furniture are very easily available in our hospitals. 1 or 2 small chairs which we can buy easily. This, as I mentioned before, the story of triplets, this has been published in the Lancet series as well as the WHO booklet on KMC. This is a wonderful story of this mother who had earlier 2 female children. These are the triplets, who all 3 females, and these were wonderfully groomed and taken care by our colleagues at district hospital. With this, I guess I'm coming to end. If I have made any mistakes, kindly excuse. And if there are any doubts, I guess there are stalwarts who can answer. Thank you. Greetings from, this is Anjanadri Betta, Hampi, from Hampi. Thank you. Thank you, one and all.
Thank you, Dr. Amaresh. Wonderful presentation, beautiful videos you have put, very neat slide, very clean presentation. Thank you, thank you, thank you.
Thank you, sir. Thank you.
Wonderful presentation. We will take up all the doubts, queries, question and answer after the second talk. You can stop sharing the slides now.
Sure.
So I request Dr. Chaitali.
Yes, sir.
Yeah. You can start sharing your slides. So,
Sir, my slides are visible, sir?
Yes. Slides are visible.
Yes,
Dr. Chaitali is a consultant neonatologist with Bapuji, and we all know her very well. And she's doing a wonderful job over there. Thank you very much for accepting our request. A warm greeting and welcome on behalf of NNF Karnataka. After your talk, we will take up all the questions. If anybody has any queries or any questions, you can post it here in the chat, or you can send a message to us as well. All right, Dr. Chaitali, over to you. Please start the session.
A very good evening and namaste to one and all. At the onset on this auspicious day, I give my pranams and namans to all my teachers. A very happy Guru Purnima day. Today, I'll be talking about, in general, common neonatal procedures. My overview of my slides will be in couple of slides. I'll be covering upon what exactly the procedures mean and what are the prerequisites we need to keep in mind before starting any procedures, the antiseptic precautions and the aseptic preparations we need to take during the procedures. One slide on pain management for the procedures we need to take care during procedures. And in general about the procedures, I'll be covering around 8 to 9 common procedures which we do day to day in our NICUs. So coming to procedure, what do we understand by procedure? Procedure is an established and official way of doing something. Basically, for our easy understandings, procedures are mainly divided into two types, that is non-invasive procedures and invasive procedures. What do you understand by non-invasive procedures? Non-invasive procedures are procedures where we are not involving any skin incisions, or neither the skin pricks are done. Such procedures are called as non-invasive procedures. Commonly non-invasive procedures which we see in our NICU is like umbilical cord cleanings, checking the weight of the baby, connecting the baby to the pulse oximeters. Everything has got its own procedures. We need to have a standard protocols for doing all such procedures. Those procedures are called as non-invasive procedures. So coming to invasive procedures, again, invasive procedures are further classified into two types, minor invasive procedures and major invasive procedures. A procedure is said to be a minor invasive procedure when the time taken for the procedure to complete is around less than 5 to 10 minutes and just a skin prick is involved, and there is no direct connection with infections to the central nervous systems. So such procedures are minor invasive procedures. The commonest ones are drawing of the blood, RBS monitoring, and sometimes heel pricks for RBS monitoring, and peripheral line establishing for the fluids management. Those are minor invasive procedures. So what are major invasive procedures? Major invasive procedures are those where it takes a longer duration, which for about more than 5 to 10 minutes, and a skin incision is needed for such procedures. And there is direct risk of infections of central nervous system like lumbar punctures, any central line placements, ICD insertions, thoracostomies are all included in major invasive procedures. So coming to the prerequisites which are necessary to be done prior to any procedures are, the first one is informed consent. Consenting is very, very important prior to start any procedure. When we talk about consenting, there are two types of consenting. One is general consent and procedural consent. General consent is taken for from the guardians of the parents. Once the baby is entered into the NICU, we take a general consent from the parents telling that the baby will be cared in our NICU. This general consent is not enough for any procedural consent. If you want to do any procedures for the baby, like you want to do an exchange transfusion in the baby, if just general consent is not enough. Specific consent for that procedure has to be taken, and every unit should have different procedures for different consent forms for different procedure. So depending upon the procedure we have decided for the baby, the consent has to be taken for specific procedural consent. Next is documentation. This is again next very important thing. We have to be very careful, because we see nowadays we are facing with many of the legal issues around the doctors. So everything has to be documented very properly. So documentation includes the time when the procedure is started, the date, time of the procedure started, the time the procedure is ended, and even we need to write the indications why the procedure was started. Any adverse events happened during the time of the procedure also has to be documented, and this has to be countersigned by the person whoever does the procedure. If preferably it will be good if we put a seal, because that is what we make sure in our unit that residents document everything and at the end put a seal which is authentic. Next, coming to aseptic precautions. All general procedures have to be done under proper aseptic precautions. Then only we can control the infections in our unit. We all know newborn babies are prone for polymicrobial sepsis and nosocomial sepsis. So aseptic precautions has to be taken properly for the each and every procedures. In the coming slides, I'll be discussing about what are the aseptic precautions to be taken for the procedures. Next is pain management. We all know all the procedures cause lots of discomfort to the babies. So pain management, according to the procedures, the pain has to be managed as per the unit protocols. So next is timeout and checklist. What I meant here timeout is, if it is a very busy unit, it is very sometimes errors are very possible if the unit is very busy. So we need to really think which procedure to which baby and what we are doing. Sometimes we land up in errors happening, like we want to do an right-sided thoracostomy for that baby. We might miss it doing it on the left side. So such error should not happen. There should be a safety pause, timeout, decide properly to which baby what procedures has to be done. Then coming to checklist, before any procedure to be started, every unit usually have a checklist. Take a checklist, follow the checklist and arrange your things so that even the simplest things like micropore scissors are not missed.
Ma'am, can you unmute?
Okay.
Yeah.
Coming to education and supervision, always all the procedures, the person who does the procedures should have been well versed with the procedures and should have at least good hands-on experiences. There are many workshops conducted everywhere for the many workshops are conducting everywhere for the postgraduates. They have it's always go for hands-on workshops, practice, and then come and do it on the newborn babies. And always it has to be supervised by the seniors or the senior residents on calls. Next, along with doing the procedures, just not only concentrating on the procedure is enough. Along with that, we need to concentrate on the vital status of the baby is also very important. So always the person who does the procedures cannot concentrate on the both the things simultaneously. It is always better to delegate this monitoring work to the other junior resident or the staff nurse who is in charge with this, so that her job is mainly to concentrate on the cardiorespiratory status, and also the most important is thermoregulatory monitoring of the newborns during the time of the procedure is very, very important. It should not happen like we have successfully done the procedure but baby has landed up in hypothermia. So such things has to be avoided. So one separate person, the job is mainly to monitor the status and the temperature of the baby, and also keeping in mind hemostasis for all the procedures.
On the left side, there is the arrow, left lower bottom. Yeah, that one. Yes, correct.
Okay, thank you, sir. Okay. So coming to the aseptic precautions we need to take for all the procedures. Here in general, I'll be covering the aseptic precautions for the all procedures. The first, for our easy understanding, aseptic precautions for the major, I've divided it into two types. One is for the major procedures, what precautions to be taken, and then coming to minor procedures. In major procedures, the important one includes two types. That is, personal preparation is very important. Then comes the skin preparation. In personal preparation, we need to the person who does the procedure along with the helper has to go for thorough 7 steps of hand washing. We all know what are the 7 steps of hand washing. Thorough hand washing has to be done, just not only with soap water solution hand washing. He has to go for a scrub hand washing for complete 2 to 5 minutes of hand washing. And then for the major procedures, along with hand washing, he has to don himself with proper barrier methods. Like he has to wear a sterile gowns with a head cap, with a mask, and sterile gloves is very important for all the major procedures. Then coming to skin preparation, if you're the skin preparation varies depending upon the time kind of procedures we are doing. If you are planning for a central line placements like the umbilical central line placements, then whole of the periumbilical area, at least around 5 centimeters of the periumbilical area has to be cleaned thoroughly with the aseptic solutions. In a circular manner, at least 5 centimeters has to be cleaned, and then this has to be cleaned again with the alcohol solutions. Never, once the skin is been cleaned, never dry the skins, because it has to air dry. That is very important. And if you're doing pick lines, then the whole hand or the whole limb has to be thoroughly cleaned. The skin, after the skin preparation is done, the part of the baby, the operational area where we are doing the procedure has to be over draped again with at least 2 sterile drapes, including the whole of the warmer and the baby, that has to be draped and covered very properly. So for minor procedures, almost the personal care and skin caring is the same, but only thing what we which is not recommended for minor procedure is draping is can be avoided, as it is okay if we don't drape, but the skin preparation and the personal preparation is very important. So coming to the commonly used antiseptic solutions, there are most commonly used antiseptic solutions for the preparations of skin is one is chlorhexidines, alcohols, iodine, or hexachloroquines are commonly used. Mechanism of action of all the antiseptic solutions are almost the same. They act by disrupting the cytoplasmic membranes by denaturation of proteins that damages the cell membranes, and they also have a good advantage of they have a broad spectrum antimicrobial activity, killing all the yeast, and good sporicidal activity. But when it comes to disadvantages with chlorhexidine and alcohols, we see they are more prone for local dermatitis and skin reactions. But when we talk about iodine, what we have, what is the another disadvantage is though it has got a good same mechanism of action and good advantage antimicrobial property, we have seen that iodine preparations have got a systemic absorption resulting in transient hypothyroidism or increase in the thyroid stimulating hormone levels. So evidence tell that this was a study I want to quote here, which was published in Archives of Fetal Diseases in Fetal and Neonatal edition in February 2018. It was this was an RCT trial which was done between two groups of babies. One group of babies, they had used 2% chlorhexidine with isopropyl alcohol combination versus 10% iodine was used for insertion site cleaning. It was seen that when it comes to the sporicidal activity and skin aseptic precautions, when it comes to the study concluded that the infection rate following using both the combination was similar, but it was seen that there was significant rise in thyroid dysfunction. There was a rise in thyroid stimulating hormone in the babies where 10% iodine was used. So it is recommended that to go for chlorhexidine and alcohol preparations rather than iodine preparations as antiseptic solutions. So coming to pain management, one slide on pain management. When it comes, it is mainly as recently we had Dr. Vijay Kumar sir speaking very detailedly about pain management during the procedures. So in general, if we are dealing with a procedure which is causing mild pain to the newborn babies, then non-pharmacological methods are enough. That is, sucrose solutions can be used. 24% sucrose solution, about 1 to 2 ml prior to start of the procedures is recommended, or other non-pharmacological methods like swaddling, cuddling, skin-to-skin contact, non-nutritive suckings, and breastfeeding can be followed. So coming to pharmacological methods, when we are having any procedure which causes around moderate to severe kind of pain, then use with drugs like Comnest is paracetamol, and morphine and fentanyl IV preparations also are used. So we all know more the number of noxious stimuli during the NICU stay has got a very adverse developmental effect in the newborn babies. So as per every procedure, pain has to be treated. Now, per se, with this information background, I will be starting with the commonly used procedures in our units. So the most basic procedures which every unit or every newborn baby we follow is, one is peripheral line insertion or peripheral vein cannulation. So coming to the indications, what are the indications for peripheral line cannulation is, we need for simple fluid administration for nutritional support when we use it for medications, for giving blood and blood products. There are some contraindications where peripheral line cannulation has to be avoided when the extremity, if there is any injury to the infected extremity, in such hands avoid putting peripheral lines to those extremities. If you're planning for any PICC line procedures, avoid those veins and use other veins. And next is irritant solutions, especially direct administration of calcium has to be avoided because they are more prone for thrombophlebitis infections. So coming to the procedure per se, before starting the procedure, we need to prepare and arrange the things. For the things needed for this is, we need to have a different size cannulas, depending upon the size of the baby, a tourniquet, alcohol swabs, betadine gloves, vacuum and transparent dressings. The correct size for the cannula has to be choiced. selected, that is mainly such joints where avoided, the veins which are present on the joints has to be avoided, or if there are any obliterated veins, better not to use those veins. This is how the tray has to be arranged before starting the procedure. And the commonly used veins is in the dorsum of the hand, you can use the venous arch, and in the forearms you have mainly the right median veins, the cephalic veins, the basilic veins can be used. In the leg, you can go for a dorsal venous arch can be used again, or a cephalic vein, saphenous veins can be used. So aseptic precaution in general I have spoken. So here I would like to play a small video how the procedure is done. With keeping in the mind cleaning the antiseptic solutions. Here I am showing a video where the saphenous veins have been used. This is how the site has to be cleaned with alcohol and spirit, and with a proper size appropriate for the baby's leg. The cannula has to be inserted. If we are not visualizing the veins properly, you can use the methods like slight tapping or warming of the limb can be done, so that you can carefully visualize. And once the you hit the vein, you get a backflow in the hub of the cannula. Slowly retract the needle out and pass your cannula, insert it totally inside. And then always, once you can see here how swaddling is done during the time of procedure. So this is how the saline flush is pushed, and see whether the cannula is well placed. Close the cap and put a proper tegaderm dressing. So coming to the most commonest complication we encounter if the proper care is not taken care for the cannula is mainly phlebitis is the most commonest complication. So for identifying, there is a simple scoring system for phlebitis. Score of 1 is given if there is associated with slight pain and redness. Score of 2 when there is associated with arrhythmias and swellings. 3 score is given when there is, along with arrhythmia and swelling, there is palpable venous cord. And score of 5 along with above signs of arrhythmia, swelling and palpable venous cord. If it is associated with symptoms of pyrexia, then it is said that it is a score of 5. Immediately the cannula has to be changed and reconsider for another cannula lines. So coming to the next commonest procedure we use in our NICU is umbilical arterial line catheterization. What are the indications for umbilical arterial line catheterization? It is done mainly in case if you need to monitor continuously the arterial blood pressures to be monitored for the child, or you want to do frequent blood gas monitorings are to be done for those babies, or blood samplings if we are planning for those babies. In such conditions, or you're planning for any exchange transfusions, in such conditions, umbilical catheter line has to be planned. So what are the contraindications for umbilical line catheterization? If there is presence of any infections, then catheterization has to be avoided. Infections, I mean if there is presence of any omphalitis, necrotizing enterocolitis, presence of any peritonitis, better to avoid umbilical arterial line catheterizations. If there are any abdominal wall defects like fistulas, if it is we have any case of omphalocele, then catheterization has to be avoided. In single umbilical arteries or cord anomalies also we can't. So what coming to the placement of the catheter, we all know where the umbilical, when we are planning for an umbilical arterial line, the tip of the umbilical arterial line has to be placed at either at a higher level or at a lower level. When you want a placement at a higher level, we have to aim it placing at a level of T6 or T9, or if you are planning for a low level tip, we have to place it at either L3 or L4 level. For this to achieve, there are two methods which has to be to decide how much length has to be inserted. One is basically what we all know, and we teach the we teach our postgraduate is measuring the shoulder umbilical length. Here, once we measure the shoulder umbilical length, that is the lateral end of the clavicle has to be measured, and it has to be measured up to the base of the umbilicus. To this, we need to add plus 2 centimeters plus the length of the stump. So for example, if we get a shoulder umbilical length after the measurement is around 14 centimeters, see here, it has to be plotted in this graph. So our main aim is it has to lie, if you want to lie at a low level, then the tip should lie somewhere at 8 centimeters. So around 8 centimeters of the umbilical length has to be inserted. This y-axis tells us the length of the umbilical catheter to be inserted inside, and the x-axis tells us about the shoulder umbilical line. So if your measurement is around 14 centimeters, then for the low level catheters, it has to be around 8 centimeters has to be inserted. And for high level catheters, the same, you have to insert around 16 centimeters. So if 16 centimeters, which tells us that our tip is lying somewhere around T6 to T9 level. So this area or this zone between the diaphragm and the bifurcation of the aorta is the most hazardous and dangerous zone. Always avoid placement of umbilical tips in this zone. Either go for a too high level or a low level of umbilical catheter placement. This is simple shoulder umbilical measurements, and or also there is one weight based formula, that is birth weight into birth weight in kgs into 4 plus 7, also tells us about how much length to be inserted. This is how the preparation tray has to be arranged. We need to take a single lumen or catheter, flush it properly. The requirements, like we need to have different size of forceps, mosquito forceps, tooth forceps, plain forceps. We need to have a scalpel blade to cut the cord, tourniquet to tie, measuring tape to measure, tegaderms for fixing. So this is how you need to have a checklist or arrange our procedural tray. So something it looks, once the tourniquet is tied and a cut section of the cord is taken, this is what we visualize. That is, umbilical vein is seen here, and these are the two arteries. So here, so this is a very small video. Once the tourniquet tied, we can see here the umbilical vein is visualized here, and there are two umbilical arteries which are clearly seen. So with the help of the forceps, slightly invert the umbilical veins, and further clearly you can visualize the umbilical artery. With the catheters, this is how with the help of the forceps that the catheter has to be pushed inside. So already we have measured, we know how much measurement has to be passed, inserted. The measurement, depending upon that marking, it has to be fixed. Once it is passed inside, see for a proper backflow and then fix it with the tegaderm dressings. So things to be remembered here is umbilical arterial lines never to be used for total parenteral nutrition. Guidelines tell that umbilical arterial lines should not be kept longer than 5 days. Teflon or polyurethane catheter materials are better preferred than PVC materials. If there are presence of any warning signs of complications, remove the line as early as possible. So what are the complications we frequently seen during umbilical arterial canalizations are? Most commonest is malpositionings are very common. The tip may malposition in either the place, and which is very dangerous. Next most commonest complications is vascular accidents. Thrombosis of the vessels, embolisms, thromboembolisms, air embolisms are also very commonly encountered following umbilical arterial catheterizations. And other complications like hemorrhage, necrotizing enterocolitis, peritoneal perforations, and metabolic complications like hyperglycemias and hypoglycemias are also common. Coming to the next important procedures, that is umbilical venous line catheterization. It is mainly indicated in cases of if you want to give IV fluids or nutritional fluids to the child. That includes mainly total parenteral nutrition for the baby. If you want to, these lines can be used for administering vasoactive drugs, for medications, for central venous pressure monitoring. In cases if you're planning for exchange transfusion, then we need to have umbilical line catheters. And during the time of emergency, that is especially in labor room situation, when you have you are dealing with a shock-like picture in the newborn babies, where it is very difficult to access a peripheral line, then we need to emergencyly put a central lines and use volume expanders, such situations. So contraindications are the same what we have discussed in umbilical arterial catheterizations, and complications are almost the same. Other complications, few to mention, are there are also more umbilical complications like pericardial effusions, cardiac arrhythmias, hepatic necrosis, portal vein thrombosis, and portal hypertensions are commonly encountered. So coming to the length, how much to be inserted, we all know the tip of the umbilical line should lie at the cavoatrial junction, that is between the inferior vena cava and the right atrium. For that, to achieve that, again the same formula, that is the shoulder umbilical length has to be measured and plotted on the graph. This is very important for both umbilical arterial catheterization and venous catheterization. Graphing, plotting on the graph and then seeing how much the centimeter to be inserted has to be practiced by all the residents whoever does this procedure. So for example, the same if the measurement is around 12 centimeters, our aim is to lie the tip in between these two lines. This is the line for the left. This tells us at the higher end, that is the left atrium or the diaphragm. Your tip of umbilical venous line should be between the left atrium and the diaphragm. It should be lying in this zone. So your shoulder umbilical length measurement is around 12 centimeters. Then the amount of catheter to be passed inside is somewhere around 7 centimeters. So this has to be calculated and then plotted. Another weight-based formula is you can use this formula also, that is 1.5 into birth weight in kgs plus 5.5. It also tells us the same measurement we need to catheters. So we are the same thing. It has to be between the position of IVC and right atrium. Depending upon the weight of the baby, 3.5 French or 5 French is used. Duration tells that this umbilical venous line can be kept as long as around 14 days. If no complications, if presence of any complications, at the earliest removal is very important. Steps of insertions are almost the same how we do for umbilical arterial catheterization. Preparation of the tray is same. Either a single lumen or a double lumen catheters can be used. This is the vein position. Vein position is always around somewhere at 12 o'clock position. If the cord is slightly shriveled down, it is usually between 9 to 12 o'clock position. You can visualize the umbilical vein. The same video I have posted here, which I have already cathetered the umbilical arterial line. So this is already we have inserted the umbilical arterial line for this, and now we have to visualize the umbilical vein, which is here, and with the help of the forceps slightly invert the tip of the umbilicus, and catheter has to be inserted as per the measurements we have measured. With the help of the forceps slightly insert the catheters. So once both umbilical arterial lines and the venous lines are placed, check X-rays are very important to check where the tips are lying. The next commonly used procedures are PICC lines, that is peripherally inserted central catheters. These are mainly indicated in case we need, again the same indications where we need to give total parenteral nutrition for the newborn babies, or intravenous fluids or medications can be given. Contraindications for these procedures is if there is already a present positive blood culture in the baby. That means if there is presence of active infection in that newborn baby, better to avoid PICC lines, because as such PICC lines are more prone for CLABSI infections. So if there is any presence of bleeding disorders in the newborn babies or limb anomalies, PICC lines has to be avoided. So equipments needed, we need to have a PICC line central kits, and other aseptic precaution equipments has to be taken care. Catheter size, depending upon the size of the baby, you need to go for 1 French catheter or 1.4 or 1.9 French catheters. This is how the procedure tray has to be arranged. We need to have a measuring tape, normal saline, gauze pads, alcohols, chlorhexidine and povidone syrups, and transpirate dressings. This is the PICC lines which we use in our NICU. This is how it looks, which includes everything in it. It has got introducer cannulas and everything in that. We can use single lumen PICC lines or a double lumen PICC lines can be used depending upon our requirements. So coming to the sites which are used for PICC lines is, you can go either for a basilic veins or the cephalic veins, or you can go for brachial and axillary veins. Or sometimes if you're planning for a lower limb PICC lines, then you can go for great saphenous veins. So coming to the insertion per se, the technique is, once we open the central line kit, the most important, the first thing we need to see or take in the central kit is, this is the introducer cannula. The advantages of this introducer cannula is, it is a kind of a peelable cannula. We can easily peel once the catheter is inserted. So either you can use the same needle which is given in the introducer cannula, or if the needle looks too big, you can separately take a 24 gauge needle which is present in the kit itself. You can introduce inside the peelable cannula. So something which this cannula is also called as fine tipped introducer cannula. With this cannula, after the cannula preparation is done, the insertion is the insertion procedure is something similar like what we follow for a peripheral line insertion. That is just how we cannulate the peripheral lines. The same way we need to hold the needle and cannulate the peripheral line. Once you see a backflow, you hit a vein, you get a blood in the hump, remove this needle out, and then we need to take the central lines. The central lines has to be inserted through the introducer cannula. With that small hole, it has to be inserted. Holding the cannula in with the help of your forceps, you have to slowly insert it with the measurement, with the amount of measured site which we have measured. So if you're planning for a upper limb catheterization, the site measurement is from the site of the point of insertion to the whole course of the vein has to be measured. up to the level of the up to the level of the sternal process. That is somewhere for the upper limb insertion, you have to keep your tip round T3 or T4 level. If you are planning for a lower limb PICC line insertion, our aim of PICC lines tip to end should be at the level of T8 or T10. Measurement is the same. You need to measure the length or the whole course of the line vein has to be measured, starting from the point of insertion point up to the whole course of the vein has to be measured up to the umbilicus to the xiphisternum. So that gives us the measurement, how much of the length has to be inserted. Once the cannula is, once the catheter has inserted to the measurement what we have decided, clean it, put a stitch, and tegaderm dressing is very important. So this is check X-ray following any procedure is important to confirm where the tip lies. So coming to the maintenance of central lines as we all know are more prone for infections. Maintaining central line is very, very important. Using sterile techniques, we need to clean the tubings every 96 hours, that is once in 3 days. If we are using central lines for total parenteral nutrition, then tubings has to be changed every 24 hours. If any port, if it is a double lumen or a triple lumen central lines, if one of the port is unused or you want to use that port exclusively only for the medications, then when the port is not used, then that has to be saline locked and covered with an alcohol impregnated cap is very important. Before connecting any IV fluids to the unused cap, it has to be cleaned thoroughly with alcohol swabs for 15 seconds with friction. All the central lines should have a continuous heparin infusion in it. A small dose of heparin infusion is needed for PICC lines, that is 0.5 ml per hour.
Can you unmute?
Has to be continuously given. Heparin infusion has to be continuously given. Something will happen. So coming to the complications of PICC lines are mainly prone for CLABSI infections, that is catheter associated bloodstream infections are very commonly seen following PICC line insertions or this is one of the most commonest hospital acquired infections which is associated with a very high rate morbidity and mortality. It can be fully preventable when proper aseptic precautions care is taken during the procedure and during the maintenance time of procedures. So when to tell that it is a case of a CLABSI? So there is a definition to tell it is a CLABSI, proven CLABSI, that is at least you need to have 2 positive blood cultures for Kamal cells within 24 hours of each other and 1 non-positive Kamal cell culture growth should be present to tell it is a case of a CLABSI. Other complications are some thrombophlebitis, extravasation of the vein, thromboembolisms, perforations of the vein, migration of the tip, pericardial effusions, and arrhythmias are few other complications. So coming to very important care which we need to take care when we are using PICC lines in our units very frequently. This is called something like bundle care approach is very important to avoid CLABSI infections. This bundle care approach mainly includes 6 important points in them. That is, the first one is effective hand washing technique before start of the procedures. Antiseptic solutions to be used is mainly 0.5% chlorhexidines with the 70% alcohol as a skin antiseptic. Strict barrier aseptic precautions, that is barrier methods to be followed during the time of insertion. Dressings to be changed whenever it is soiled and or every 7 days. And this is very important, that is effective use of ANTT. What is ANTT? That is aseptic non-touch technique method has to be followed whenever you are using whenever you are changing the IV tubings or whenever you are giving any medications through PICC lines. The last and the important one is unnecessarily do not keep the PICC lines. It has to be early removed and reviewed daily per shift by one of the staff per shift. So it has there was one journal meta-analysis and review also tells that this bundle care approach following PICC lines helps to reduce central line associated bloodstream infection. So this bundle care approach has to be followed during the time of insertion, during the procedures, and in the duration of the stay of the PICC lines. So what one slide on aseptic non-touch technique. This is a pictographic representation how we need to do this ANTT methods, especially for giving medications or changing the tubings. This preparation is mainly divided into 3 zones. One is preparation zone, patient zone, and decontamination zone. In preparation zone, the person whoever wants to give any medications, the first thing he has to clean with hand and rub and soap solution, clean the tray where he is placing the medications, gather all the equipments, once again go back and clean the hands with alcohol, wear a non-sterile gloves, arrange the medications, keep it in the tray. And then comes to the patient zone. Again, the unsterile gloves has to be removed, clean her hands again with alcohol hand solutions, and then only she has to touch the port where the medications to be given. That port, before giving medications, the person has to thoroughly clean it with at least for 15 seconds with the alcohol swab with friction. And then this is how the medicine has to be administered. After the administration, she has to dispose the sharps and equipments, remove her gloves, again clean her hands. And then this is also very equally important. The tray which she has used for preparing the medication has to be again cleaned and place it back. This aseptic non-touch technique practice following in the units drastically reduces the incidence of CLABSIs in our units. So coming to the next important procedures, that is lumbar puncture. Lumbar puncture, we all know it is a procedure which is done by using an aspiration needle. The needle is mainly placed in the subarachnoid space of the spinal cord, especially mainly at the 4th intervertebral space to collect the cerebrospinal fluid for the diagnostic purposes. So what are the indications for lumbar puncture? It is mainly done in cases of suspected meningitis, encephalitis, in case suspected metabolic disorders, or if you are to monitor the antibiotic antimicrobial therapy in presence of any central nervous system infections. This is very controversial. This is mainly this one indication is quite controversial. If you want to, in case if you are having a case of a post-hemorrhagic hydrocephalus, sometimes to drain the CSF, you can use lumbar puncture as one of the method. It is contraindicated in conditions already if the child is having any cardiovascular compromise, respiratory compromise, if there is any presence of active seizures in the newborn babies, thrombocytopenias or coagulopathy disorders in the newborn babies, local infections, that is especially the intervertebral spaces are infected, meningomyelocele, vertebral anomalies, then this procedure has to be avoided. So what are the complications following lumbar punctures? The commonest complication we usually see is because of the incorrect position, respiratory arrest and hypoxias are common. Failure to obtain a specimen is again another important complication, what we call as dry tap. The next one is traumatic tap. Here, when we talk about traumatic tap, we should remember whether we are dealing with a case of a simple traumatic tap or something else, like especially we are having a case of a cerebral subarachnoid hemorrhage or bleed. So we need to differentiate bedside whether it is a case of a traumatic tap or a bleed. In cases of another important complications is that is spinal hematomas and abscess formation following procedures. In pediatric cases and adult cases, we usually see post-dural headaches are commonly seen. Sometimes if our position, the spacing is not correct, then there is every chances we hitting the spinal cord, or nerve damage is also seen if the insertion is too high. So this is how the LP tray has to be arranged. Take all necessary equipments, the solutions for the antiseptic solutions to clean. We need to have the LP needles. You can either go for the LP needles, or sometimes you can also go for a 21 gauge or a 22 gauge needles also can be used. Or sometimes these are pharmaceutically available in pharmacy. LP kits are available. You can use either the LP kits also. So what are the positions which are required, recommended for lumbar puncture? There are 2 positions which are recommended for lumbar puncture. You can either go with a sitting posture, or you can go for a recumbent lateral line, that is recumbent posture. Most in our unit we follow this posture. The things to be remembered, where to insert the needle and how the position is given is very important. The main aim is Too much of flexion of the head is very dangerous. The neck should not be flexed too much. The flexion pressure has to be applied at the level of the shoulders and at the level of the hip. It should be something in a kind of a baby should be in a fetal position, more of flexion at the level of the intervertebral space. And we need to draw an imaginary line at the level of the both ilia crust, and this imaginary line usually cuts at the level of L3 intervertebral space. This is the space we need to do the tapping. And the important some of the landmarks which we need to remember remember doing lumbar puncture is we should never go the space above L2 and L3 space. This is the reasons for this is in the newborn babies. The newborn babies have got a slightly extension of the spinal cord when compared to the adults. It is said that at the time of the conception, the whole of the entire length of the vertebral column, we see the spinal cords. As the gestational age increases or as the gestation progresses, there is slightly decline in the length of the spinal cord. So at the age of 24 weeks of gestation, the spinal cord ends at the level of first sacral vertebrae. When it comes to a term baby, this level ends at L2 and L3 as compared to an adult which ends at L1. So this is the reason why we need to prefer L3, L4 or L4 and L5 space in the newborn babies rather than L2 and above space, because we are having a high risk of hitting the nerves and the cord. The next commonest procedure is the chest tube placement or thoracostomies. We all know what is the indication in cases of evacuation of pneumothorax, especially the tension pneumothorax. I'll not go into the details of this. Pneumothorax is mainly defined in presence of air in the space between the parietal pleura and the visceral pleura. If it is a case of a spontaneous pneumothorax and baby is stable, we need not do any procedures. If it is a case of a tension pneumothorax where we see a child is having a sudden collapse with bradycardia, hypotension and cyanosis, then emergency procedures, immediately we need to drain the pneumothorax. So bedside recognition, it has already been discussed in previous webinars. This is how the trans-illumination test is done and confirm the pneumothorax, and this is how the chest X-ray looks for confirmation of our pneumothorax. So once we have confirmed that it is a case of pneumothorax and you are planning for a needle thoracocentesis at the emergency, and then we need to plan for ICD insertions. For needle thoracocentesis, the things we need to have is you need to have a butterfly needle is very important. That is either 21 or 23 gauge butterfly needle. You need to have a one three-way cannula and one 10 ml syringe. This is how the pictorial representation looks like for the arrangement of needle thoracocentesis. This is your butterfly needle, that is 21 gauge butterfly needle connected to one three-way cannula, and to this it is connected the 10 ml syringe. This butterfly needle, the site where we need to insert is mainly at the second intercostal space, that is at the mid-clavicular line. We have to insert this. Along with slightly insertion, we need to give a negative pressure with the 10 ml syringe until you hit the pleural space. Once you hit this space, you get a give-over kind of feeling and the whole of air is pushed out in the syringe. If the person is not comfortable with a three-way cannula or a 10 ml syringe, he can also use an alternative, that is, he can just use a 21 gauge butterfly needle. The end of this needle is something collected in a underwater bowl, where you take a bowl, place of water in it, and the end of the three-way cannula, end of the scalp needle is put in the bowl. So once you puncture the pneumothorax, you see the bubbles in the water. So this tells that you have entered the pneumothorax. This is an emergency procedure to stabilize the baby. Once you have stabilized the child, then you need to plan for ICD insertion. So what are the site you need to put an ICD? This is the safety triangle site. These are the preferred sites. Safely you can insert the ICD either at the 4th, 5th or 6th intercostal space. The insertion has to be done in between the mid-axillary line and the anterior axillary line. So this is the safety triangle where we have to aim for inserting the ICDs. So Seldinger technique is the technique used for ICD insertion. That is, Seldinger technique is used. This is how we need to arrange our trays with an intercostal drainage catheter with drapes, tegaderms, forceps, mosquito forceps, and other things with a underwater seal drainage to connect it to the intercostal space, intercostal needle. So the procedure, this is a small video for the procedure. So this is how we need to first locate this space, the fourth or the fifth intercostal space, check it, and then you need to give a local infiltration with 1% lignocaine. After the local infiltration is done, we need to do a small skin incision, that is around 0.5 to 1 centimeter of skin incision is done. With the help of a mosquito forceps, you need to go inside, pierce the skin, and you need to pierce the pleura, which is very important. Once you hit the pleura, you get a kind of a giveaway feeling. With the tip of this mosquito forceps, place your intercostal drain tube. With this, we need to insert it. Always the tube should be inserted such a way it is placed anteriorly and in upward directions. And once around, at least there are numerous holes on the intercostal drain. See to it that all the holes are placed inside the pleura for good evacuation of the air. So once it is placed inside, remove the mosquito forceps. The end of the intercostal drain has to be connected to the underwater seal drainage where the air is drained. So this is how the procedure is completed. Once you place an intercostal tubings, it has to be stitched with pursing sutures, has to be sutured. Tie the tube properly to the skin so that it is not displaced. And finally, it has to be covered with glycerin petroleum dressings or dry gauze dressings, and then with the proper tegaderm dressings has to be placed.
Ma'am, please unmute.
So chest tube removal is done only in case if there is very minimal drainage. When there is total absence of air leak is documented.
Ma'am, sorry, again unmute, ma'am, please.
Okay.
Yeah. Continue, ma'am. Continue.
Chest radiograph clearly chest radiograph shows clearing of the pneumothorax. Then you can plan for removal of the chest tubes. So coming to the next commonest procedures is exchange transfusion. Exchange transfusion indications are it's mainly in cases of RH incompatibility, or you're dealing with a case of ABO incompatibilities or autoimmune hemolytic diseases. Sometimes in conditions like, though it is a case of unconjugated hyperbilirubinemia, but it is a very high rising serum bilirubin values where there is high risk of bilirubin encephalopathies, then you need to do exchange transfusion. Sometimes as an adjunctive therapy for management of sepsis and DICs. Also you can use as an adjunctive therapies for uremic encephalopathies also. So coming to exchange transfusion, either it is partial exchange transfusions are mainly done for polycythemias. I need not go into this slide. We all know how the it is calculated using the formulas. Coming to double volume exchange transfusion, the formula used for calculation is that is the estimated blood volume into 2 into baby's weight. The blood volume taken for the babies is 80 to 85 ml for preterms, for term baby, and 100 ml for preterm babies. Calculate the amount we need to exchange transfusion, and the procedures for double volume choice of blood for exchange transfusion is very important. If you are having a case, if the mother is a O positive mother, and if the infant's group blood group is either OA or AB, you need to use O blood group, that is donors, the blood for exchange transfusion to be used is O positive. If the mother's blood group is AB or AB and infants is OA or AB, then go for baby's blood group for exchange transfusion. If you are having a case of a RH negative incompatibility case where the blood group of the mother is RH negative and the infant's blood is either it is a positive case or a negative case, we need to use a RH negative blood for exchange transfusion. So coming to the procedure per se, what is the procedure used for exchange transfusion? We need to use the most commonly preferred procedure is single catheter pull push technique is used for exchange transfusion. This is how the pictographic representation of the arrangements for the pull push technique looks like. As we have discussed, the umbilical venous catheterization has to be done. The method with the shoulder umbilical measurement, which we have discussed initially. So first cannulate the umbilical line. The end of the umbilical line has to be connected to two three-way stop clocks. And the end of the second stop clock, you need to connect to a syringe, which is used for push-pull technique. The first stop clock, that is which is proximal to the umbilical catheter, has to be always connected for the blood to be withdrawn from the infant. The end of this is to be connected with a drip set tubings, and that has to be the proximal cannula, three-way stop cannula is always to be connected to withdraw the blood from the infant, and the second three-way cannula has to be always connected to the donor's blood and the connected to the donor's blood. So this is a small video recording. I am going to show how we have to coordinate ourselves with the opening and closing of the three-way stop clock. So here you have to connect to three-way stop clock. The first step always is to withdraw the blood from the baby and see how the cannula should be. The openings of both the cannula should be straight like this so that the blood is drawn out. Close the port of the first one. You have to draw that blood out. The pulled out, that is the baby's blood, has to be pulled out and collected it in one of the container you can collect. The third step is always take the blood of the donor's blood. Look at this is how the stop clocks should be, and again the donor's blood has to be pushed inside to the baby. So something like there are very important 4 steps which the person whoever does this needs to have lot of coordination between opening and closing of the stop clocks. It should not happen like you have taken the donor's blood, instead of pushing the baby, the donor's blood is outside. So arrangement is very important. And a word about the aliquots. To begin with, start with a very small aliquots, that is 5 ml, and depending upon the status of weight of the baby and the stability of the baby, you can slightly increase the aliquots to about 15 ml. And remember, the first aliquot should be always full. The baby's blood has to be removed out, should be your first aliquot. Coming to the another technique which can be used for exchange transfusion is double catheter pull push technique, where you need to catheterize both the umbilical veins and the umbilical artery has to be catheterized. And always when you are using double catheter pull push technique, the umbilical arteries are always used for drawing the blood, and umbilical veins are always used for pushing the blood. There are many combinations which you can use for in and out techniques. The one which we do, or which is easy with less additional power or good synchronization, is usually achieved with this single vein, umbilical vein and in-out catheter. Then compared to a double catheters, that is umbilical vein and umbilical artery, or you can either go for a peripheral vein and peripheral arteries. You can go for peripheral vein and umbilical arteries. And also you can go for peripheral vein and umbilical vein. These are the different options or possibilities where you can do the procedures. So coming to the complications following this procedure, most commonest complications are they are more prone for hypothermias, hypoglycemias, hyperglycemias, kalemias, calcemias, magnesiemias, acid-base disturbances are commonly seen following this procedures. Thrombocytopenias, polycythemia is sometimes seen. And necrotizing enterocolitis is also some of the commonly encountered complications. So coming to the next procedure, that is peritoneal dialysis. What is the indications of peritoneal dialysis? When we are having a case of acute oliguric renal failure, in cases of persistent or unresponsive hyperkalemia, when there is a rising blood urea level that is around more than 125 milligram per deciliter, or if there is rising value of 20 milligram per deciliter every day, or if there is serum creatinine level of more than 3 milligram per deciliter in cases of severe and persistent metabolic acidosis, in cases of suspected inborn errors of metabolism, that is hyperammonias or any drug toxicities, we need to, these are some of the indications for peritoneal dialysis. So contraindications for peritoneal dialysis is in cases of any multiple abdominal surgeries, abdominal wall defects, in cases of diaphragmatic defects, abdominal wound infections, or intestinal perforations or peritonitis. This procedure is not to be done. So composition of fluids, normally the fluids are available in the pharmacy. You can, depending upon, this is what the compositions are available with different strengths of glucose infusions, that is 1.5% and 2.5% of strengths are available. Depending upon the ultrafiltration, you can increase the strengths of the glucose concentration. A technique for peritoneal dialysis is you can either go for manual exchanges or automated exchanges using peritoneal dialysis machine can be done. Before starting the procedure, you need to insert the PD catheters. It has to be inserted either in the right or the left pelvic cavities. One single cycle of peritoneal dialysis should mainly include, should consist of a inflow time for about 10 minutes, around dwell time of about 20 to 40 minutes, and an outflow time of about 10 to 15 minutes. Always start the peritoneal dialysis with a low volume, that is about 5 to 10 ml per kg. You can increase up to 50 ml per kg and slowly increase the dwell time also from 10 to 20 minutes. You can go up to 1 hour of dwell time, and removal time, almost outflow time is almost the same, around 15 to 20 minutes. So always start with a small volume, small dwell time, and then you can slowly increase the dwell time and the flow volume. So complications here are hyperglycemias, hypo and hypernatremias, hypo or hyperkalemias, peritonitis, bacterial fungal sepsis, leakage around the peritoneal catheters, bleeding into the peritoneal cavity, or sometimes there is high risk of migration of peritoneal dialysis catheter itself. So these are some of the common complications. So coming to the last procedure of presentation, that is endotracheal intubations. Commonest indications, there are, I have just only a few indications I've mentioned here. There are many other indications for endotracheal intubations. Mainly I have concentrated on endotracheal intubations in labor room. When if a newborn, even after giving effective positive pressure ventilation with face mask, there is no improvement, then we need to intubate the child. Before starting chest compressions, we need to intubate the child. Special circumstances like surfactant administration also, you need to intubate the child. So coming to the per se procedure or the intubation equipment tray, the things we need to keep ready is we need to have a laryngoscope with different sizes of blades. Depending upon the weight of the baby, you need to have size either 0, 0, 0 or 1. 0, 0 is used for extreme preterm, 0 is used for preterms, 1 is used for term babies. You need to have an extra pair of batteries, different sizes of ET tubes. We need to have a measuring tape to measure mainly the NTL length, so that you can decide at what level you need to fix your ET tubes. The micropores or the to fix the ET tubes, and stethoscope to confirm the placement of the ET tubes. So coming to the size of ET tubes to be used in neonates, if the baby is less than 1000 grams, we need to use 2.5 size. 1000 to 2000, 3 mm of ET tubes are used. 2000 to 3000, we need to use 3.5 size of ET tubes. More than 3000 grams of baby, we need to use 3.4 to 4 size ET tubes. So what is the position? Always remember, before the intubation procedure, the person whoever intubates the procedure has to come towards the head end of the baby and then start the procedure. The position of the baby should be, this is the correct method of position, that is something slightly sniffing position, so that you can visualize the airways properly. Too much of hyperextension and too much of flexion has to be avoided. To achieve this position, either you can go, you can use a shoulder roll supported below the shoulder, so that you can easily visualize the airways. Once the airways are visualized, what you see is the epiglottis, vocal cords, and this is where the glottis is seen. We need to pass the ET tubes. So coming to the holding of the laryngoscope blade, Always the laryngoscope, this is the correct method of holding the laryngoscope. The laryngoscope blade should be holded in the left hand. Either you are a left-handed person or a right-handed person, the blade should be, the handle should be always holded in a left hand, and ET tube should be in your right hand. You have to encircle the thumb anteriorly over the handle and other fingers posteriorly. Never visualize, hold the laryngoscope handle in this way, because the thumb hampers the visualization of the view. This is very important. And lifting the umbilical, lifting the blade should be always perpendicular to the handle. Once you, how to insert it, the insertion has to be, the laryngoscope should be placed from the right side of the mouth, slowly starting from the right side of the mouth, slightly push it inside, place it on the base of the tongue, bring it to the midline. The structure what you see is the vallecula and the epiglottis. If nothing is visualized, slightly the tip of the laryngoscope blade can be placed on the epiglottis and pushed up so that you can see the vocal cords, or the glottis can be visualized. So this is something how the ET tubes look. The black color markings, what is called as the vocal cord guide. This is something, an approximation to tell us that this vocal cord guide should be lying at the level of the vocal cords. That means it tells us it is lying at the level of the carina. So coming to the insertion, depth of insertion, this is the chart. You can place the chart in front of our NIC, in the NICU, so that you can directly see the chart and decide what length you need to insert. Or you can measure the NTL length +1. What do you mean by NTL length is from the nasal septum to the tragus length, you need to measure and add 1 centimeters. That tells us the tip where you need to fix the umbilical line. Like for example, if you are having a baby of around 2.5 to 3 kg, the line of the tip should lie at the level of 8.5 centimeters. It has to be fixed. So coming to COVID situations, what we are seeing nowadays, what are the special precautions we need to take during intubations in COVID situation is, one is, again, personal preparation is very important. Proper donning and doffing of PPE kits, complete aseptic precautions to avoid the aerosols, and we need to resuscitate in a negative pressure room. Preferably, it is said that cuffed ET tubes can be used during the situations of COVID times, mainly for the aerosol exposure to reduce, and go for a closed suction procedures in cases of a COVID positive cases. So closed suction catheters, a small video for this closed suctions, how it is done. The ET tube is fixed to the end of the ET tube has to be removed, and it has to be fixed with one Y-shaped cannula. This one end has to be connected with the surface of the ET tube, and the other end permanently we need to fix a suction catheter. And that end of, this is how the suction catheter looks, and the suction. This end has to be connected to the suction catheter. The end of this suction catheter, suction machine, and it has to be connected to the suction catheters. This color coding tells us how much we need to insert inside. Yeah. The color coding tells us how much insertion of the suction catheter has to be done. So this is the place we need to apply the suction pressure, and the tube moves inside. So once the tube is moved inside, the machine sucks itself. So closed suction procedure has to be followed in situations like COVID situations. So the commonly observed errors during the intubation procedures, what we see is too much of hyperextension of the neck is most commonly encountered. And excessive pressure is mainly placed on the infant's gum by the blade. That is something most of the beginners do, a kind of a rocking movements upwards and downwards, which hampers the visualization. So traction should be applied always parallel to the baby, rather upwards. And too much of tube is inserted, it enters into the right main buncus. These are some of the commonly observed errors. So this was my last procedures. So my key messages for common when we are doing any procedures is, all procedures should be done with a strict attention to safety, infection control, and with complete documentation. Something like we have done many procedures, but we losing the baby at the end is like we losing the battle. So all the procedures has to be done under strict aseptic precautions. And procedures are very painful and uncomfortable to the babies. So proper care should be taken for proper environment of the baby, and also use drugs whenever needed. Thank you for patient hearing. And also like to thank the NNF Karnataka for giving me this opportunity. Thank you, sir.
Thank you, Dr. Chaitali. Wonderful presentation. Almost you have covered most of the procedures which is being done in an ICU in a very clean and neat way, and in a very most practical way.
Yes, thank you, sir.
Now I request Dr. Raghavendra.
Yeah, I am here, Prashant.
Yeah, I request Dr. Raghavendra to moderate the session and take up the questions.
Okay.
And few questions.
Thank you, Prashant.
Sir, few questions Dr. Dinakar sir also might get. If he has any questions, once Dr. Raghavendra's session questions are done, then we'll Dinakar sir can take up. Dr. Raghavendra, over to you.
Thank you, Dr. Prashant, Dr. Amaresh, and Dr. Chaitali. That was a wonderful session. You made things very simple, and just few questions in the chat box which I need to be discussing. First, few questions to Dr. Amaresh. Dr. Amaresh, you are here. Dr. Amaresh.
Yeah.
Dr. Amaresh.
Sir, ready? Yeah, tell me, sir.
Yeah, few questions which they have put in chat box.
Yes.
At what gestation age you need to stop the KMC, and when to stop the KMC?
Sir, most of the babies themselves decide. Ideally, we stop by when the baby has gained around 2,500 grams. But once the baby becomes uncomfortable, is crying excessively, and baby itself decides when to stop, more than the exact gestation age or weight. Ideally, we take it as around once the baby reaches 2,500 grams, we can stop the KMC.
In your unit, at what weight you start the KMC?
Sir, any babies less than 2.5 kgs, we start, sir.
Okay. And few more questions is, what about the high risk babies which you are managing, like SGA, IUGR babies, and any CHD babies? How are you managing with the KMC?
Sir, most of the babies, once they are stabilized, we start KMC, sir. Once the babies decreased oxygen demand, or once the baby is off CPAP or ventilator. Ideally, in our unit, we are managing once the baby is off ventilator or CPAP, once the baby has minimal oxygen requirements, if the baby is maintaining saturation with nasal oxygen, we start the babies on KMC.
So basically, you want to say that when baby is hemodynamically stable and tolerating feeds, you are going to put on KMC, right?
Most important point is when the baby is hemodynamically stable, we start the KMC.
So what about feeding practices during the KMC? What are your recommendations about feeding?
Breastfeeding. That's what we practice here. If the mother is not able to get the express the breast milk, we use wet feeding. We take the mothers who are there in the unit. We ask them their feeds. Ideally, because of most of the babies are preterm babies and are at risk for necrotizing enterocolitis, we always start with breastfeeds. Once the baby's feeds have been escalated, we start with if the mother is not able to express the breast milk, we start with top feeds. Otherwise, 95 to 99% we start with continue with the breastfeeds itself.
And most of the babies, if the babies are very low risk, low birth weight, till they are around 1.4 kgs, we give them NG2 feeds. And once the baby crosses around 1.4 kgs, we start them on exclusive breastfeeding, ideally.
Okay. What about before giving baby for KMC? Do you take consent, or what are the risks you are going to explain before giving baby to the mother?
Before taking the consent, we educate the mother the needs. We have pasted with several photographs and posters in our KMC unit. We ask them to go through that, and our nurse also tells us the benefit, explains the family the benefits of kangaroo mother care. And with this, once the baby's hemodynamic is stable, we start. If there's any desaturation, we usually connect the pulse oximeter to the baby, and we also ask the nurse to continue monitor. We also educate the mother to look for danger signs in the baby. We ask the mother to look for change in color or any change in temperature if the baby feels cold, or if we also ask for if there is any look for a respiratory pattern also. This we ask the mother to this, and with this we take up their consent and then go ahead with games.
Okay. Dr. Rama, regarding both parents are working, so in that situation, what do you recommend if they have a preterm babies? How regarding like short, medium, and long? You have told something regarding the hours of KMC.
Yes,
so what about that? What do you recommend for those parents?
I personally would advise both the parents. This is the best thing for them to happen. The baby is more important than any other work in the world. So I would personally request the mother to take a break till the baby's at least around till the baby is around 6 months of age, or if maybe a mother, someone else can take care. In spite of that, if they are not willing, luckily and thankful to God that I have not faced any kind of those situations as such. And if at all the parents feel that everything else, their work is more important than baby, then there is always grandparents. For them, the grandchildren of the world to them, and nothing else matters. We ask them to come forward. And I have shown a photograph where a grandmother has taken care of the whole child, where the mother was postnatally depressed, and that grandmother is taking care of the child, and the baby is now almost 1.3-year-old.
Okay. Thank you, Dr. Amaresh. Really, that was a wonderful session, and it was very informative. Even in our level 3, level 2 unit, we are practicing KMC. All preterm babies who are hemodynamically stable and tolerating feeds, we are shifting them to the KMC ward. Definitely, this KMC is a big boon for us. It will help us definitely in decreasing the hospital stay for preterm babies, and definitely we have prevented the nosocomial infection also. And we have motivated the mothers with the same thing, whatever audio, video thing. And definitely KMC is really it is a big boon for managing the preterm babies. Thank you, Dr. Amaresh. That was a wonderful session with you. Coming to Dr. Chaitali, there are few questions which are in the chat box, which I need to discuss. So what are the precautions you take during canalization for unstable babies? So always we do get the unstable babies in our NICU in a triage area. So what are the things? Canalization is definitely difficult. What are the things you take precaution during canalization of such babies?
Canalization, Raghavendra, they meant the PIC lines or simple?
Yeah, peripheral lines or peripheral lines, whatever.
No, see,
baby is very unstable. PIC line or whatever. What are the things you take care?
Always first, stability of the baby is first and foremost thing. If the baby is really very unstable, and if it is a fresh newborn baby with an unstable baby, emergently you can cannulate the umbilical line, stabilize the child, and then you can go for peripheral lines. Always that option is there. Umbilical lines in a newborn baby's umbilical line catheterization, however sick the baby is, you can visualize the umbilical veins, catheter the umbilical veins, give volume expanders, give glucose correction through the umbilical lines. You can see that stabilize, you can do that, and peripherally you can cannulate. If the baby is not very sick, you are not visualizing because of any acrocyanosis or something like that, you can do some alternative measures, like you can tap the vein, you can use some warm packs or warm the baby, and then you can cannulate it. But always
Basically,
first priority.
Yeah, basically you want to say that first you must make baby stable by keeping baby warm. So acrocyanosis, anything is there. You just need to, that you need to speak. Okay. See, what about the pain management in your unit? few patients, a few
See,
chats
as
are
I
there.
have
What about the
decided,
pain
as I've
management you are
already discussed,
practicing in your unit? What are the pain managements you are
in
practicing?
our unit, that is what I have discussed. If we are doing a procedures where the discomfort is only a kind of a mild pain to the baby, always go for non-pharmacological methods. Like for any peripheral line insertions, even sometimes umbilical vein catheterization and arterial catheterization as such per se doesn't require any pain, because umbilical when you are not handling with any nerves or vessels in the umbilical lines. So you can just go for simple like swaddling, tucking, give the baby, you can use tucking or swaddling methods, non-pharmacological methods. If you're doing procedures where you baby experience a pain, kind of a moderate to severe pain, especially like you're doing ICD insertions, then local infiltration is of course definitely very important. And also for the intubation procedures, you need to sedate the child with either morphine or fentanyl depending upon unit protocol. We use morphines in our unit, and local infiltration we go for lignocaine preparations. Sometimes we do use even sucrose preparations, give sucrose to the baby if mild pain, and then start the procedures.
One more question they have asked is, you have already spoken. What are the precautions to be taken during umbilical catheterization, during umbilical catheterization and after catheterization?
During the time of the procedure, umbilical catheterization, the main foremost I want to stress upon is aseptic precautions is very, very, very important. Follow all the aseptic precautions, gather all the things. The operational area and the peri-umbilical area has to be thoroughly cleaned, and then only procedures have to be done. If sometimes avoid the procedure if you feel there is a single umbilical artery, then do not go for the procedures. Post procedural care, I have already spoken. You have to follow something like an aseptic non-touch technique has to be followed when you are giving when you are drawing the blood or giving any medications through your central line placements.
Okay, you need to put heparin also, you have spoken already. You need to keep the IV line patent also. That also you have already explained in your slide.
Infusion is must needed for PIC lines. Sometimes your umbilical arterial lines and venous line, if you are having any continuous fluid infusions, is enough. There is as such no recommendation that it is heparin has to be used. Flush it properly before insertion, and then if you have a continuous infusion, that is enough. But heparin infusion is must needed for PIC lines.
When you are going to remove the umbilical arterial line and when you are going to remove the umbilical venous.
Recommendation tells that umbilical venous line can be kept as long as for 14 days if there are no complications. Complications, I mean there is no leakage at the site, no blood oozing at the site of the umbilical cannulization, no infections like upcoming any necrotizing enterocolitis or peritonitis. If there are no infections, then you can keep an umbilical venous line for at least 14 days. Umbilical arterial lines, the CDC recommendation tells that do not keep after 1 week. 5 to 7 days is maximum recommendation for arterial lines.
Okay. One more question is, what are the advantages? Like you have spoken about PIC line and central catheterization. Which is better?
See, again, it depends how the course of the newborns.
Even your experience also you can speak whether PIC line is better for you or umbilical catheterization.
See, again, it depends on the weight of the baby and what kind of the baby is. If it is a very preterm baby, small baby, which needs to stay in NICU for a longer time, then preferably go for PIC lines. Especially for babies less than 1500 grams, go for PIC lines, because definitely these baby needs to stay for a longer time, and every time pricking a peripheral line once in 3 days is also very noxious, again prone for infections. So go for PIC lines. For a smaller babies. If it is a bigger baby, small duration stay, you can very well use peripheral lines.
Okay, and one more thing is, you have spoken about the umbilical puncture. So what are the complications do you expect in a neonate post umbilical puncture? What are the precautions?
Raghavendra, can you repeat the question?
Sorry, lumbar puncture. Sorry.
Okay, sir. Can you repeat the question, Raghavendra, please?
What are the things you should you'll be taking care post lumbar puncture?
Okay, post lumbar puncture. Yeah, Post-lumbar puncture as such in the newborn babies, cardiac stability and respiratory stability is very important. If the positioning is not properly given, every chances baby may go for an hypoxic arrest. So that is what I had stressed. Positioning is flexion of the, too much flexion at the level of the neck has to be avoided in the newborn babies. So there is risk baby might go for an arrest during the procedure or after the procedure also. So that thing important is positioning of the baby is very important when you're doing lumbar puncture procedure. Post-procedural as such newborn babies, if it is in a case of a thrombocytopenias or something like that, or any coagulation disorders, there might be some risk for the baby as such. Otherwise, you usually don't encounter any cases. In a pediatric case, you might see for any headaches or anything.
Okay, thank you. And one more question is, you have spoken about the partial exchange. They have asked when to do the partial exchange in polycythemia. In your experience,
again,
you are
as
going
the
to do
protocol tells, when your PCV is more than 70%, go for a, again it is divided into more than 70% symptomatic PCVs or asymptomatic polycythemias. If it is symptomatic polycythemia more than 70, you have to go for exchange transfusions.
Okay. And coming to one more thing, you have spoken about the exchange transfusion, right? So what is the role of exchange transfusion in severe neonatal sepsis and in bind?
Yeah, as I've clearly mentioned, there is no clear-cut indication that saying exchange transfusion will help. It is something like an adjunctive therapies. We use exchange transfusions. Per se, it is not a treatment. Exchange transfusion is not a treatment for a sepsis case. It can be used as an adjunctive therapy. Few studies tell that it is like something like you are removing the infected blood and transfusing it with a fresh blood. So that along with the blood, you remove all the toxins and it is replaced by a fresh donor blood. It is always an adjunctive therapy, not the per se therapy for treatment.
What about exchange transfusion in a bind? When you are going to do?
Okay. Again, this is a very interesting question. In case of bind, already if you have documented and you have clearly diagnosed that already child has entered into encephalopathy and you are dealing with a case of a stage 1 and stage 2 bind, doing exchange transfusion at this stage is not beneficial. It is just for the sake of treatment we have to give. Clearly, we need to explain to the attenders prior to the procedure that this per se, doing this procedure will not change whatever damage has already occurred. It is only for further progression of the bilirubin can be avoided by exchange transfusion. Never it will help the already caused damage to the brain. This has to be clearly explained to the attenders and then only do the procedure. This is very important. Already you have documented bind. Per se, exchange transfusion will never help for a bind cases.
Okay. And last question, Dr. Chaitali, it is same thing you have already given in your slide. When to do a peritoneal dialysis in a neonate?
Yeah, as such, I have put the slide on peritoneal dialysis, but frankly speaking, I never did even a single procedure of peritoneal dialysis in my unit. Whatever I learned from my sir, Dr. Guru Prasad sir, we rather prefer adjunctive therapy like single volume exchange transfusion, which per se acts like a peritoneal dialysis. But I have a very little experience on peritoneal dialysis. But indications are like whatever I've explained, when there is rising serum creatinine level and rising blood urine nitrogen levels, peritoneal dialysis is helpful.
Those are few questions which were in chat box, and I have discussed everything with you. And you made things very simple, Dr. Chaitali. This was all the questions, whatever there are in chat box, you have given your thing properly. So that was a wonderful session. Thanks for joining this webinar. From the NNF Karnataka, we thank both Dr. Amaresh Patil and Dr. Chaitali for joining this wonderful session. Thank you, one and all.
Sir, can I ask questions?
Dinakar, sir. Yeah,
Please,
Dr. Dinakar,
please
sir, can you take over?
Myself, Dr. Naresh, can I ask question?
Yes, sir.
Yeah.
Yes, sir.
Yes.
Dr. Naresh, please go ahead. Go ahead.
Sir, does the kangaroo mother care helps in the initiation of the breast milk, breastfeeding? Helps in the initiation of the breastfeeding and,
Sir, yeah.
and makes the breastfeeding successful. Another helps in the maintenance of flow of the breast milk.
Sure, sir. It does, sir.
The prolactin stimulation in the mother.
It does of increased stimulation of the mother, increased stimulation of the nipple receptors around the in the areola. That's one. And there, because of increased bonding and the decreased stress level in the mother, it does increase the prolactin levels in the mother, and it does help in the secretion of milk, sir.
Helps in the breast milk flow also.
Yes, sir. Sure, sir.
Does the kangaroo mother care helps in the postpartum bleed in the mother? I want to talk about the lochia, which is present in the most of the mothers.
Infection.
Is there any study about it?
Postpartum? Sorry, sir.
Bleeding there. Once the oxytocin is liberated, the uterus starts contracting.
Yes, sir. Because of increased breast milk feeding, it in turn releases more of oxytocin, sir. This helps in contract. This can decrease the in the mother postpartum hemorrhage. One, but ideally the KMC is given after once the baby is stabilized. Initiation of breastfeeding itself can reduce postpartum bleeding.
Sir, in the extreme of temperature, that is in the high humid temperature, environmental temperature, or extreme, or in the very low temperature, should we avoid the kangaroo mother care?
No, sir.
When the temperature is very low, very high.
Sir?
When the environmental temperature is either very low or very high, should we avoid kangaroo mother care, sir?
No, sir. We can continue kangaroo mother care. Only thing we need to make sure that the baby is adequately covered with the head covered with a cap and hand and gloves being covered with the cap mittens. And the mother and the baby are covered outside with a binder like a shawl or any this thing can be used. But the skin to skin contact can continue.
We have discussed many things about the various procedures and various safety measures taken during the procedures. Should we follow safe injection practices as well? Regarding the safe injection practices.
Madam Chaitali, madam, this question is over to you.
Sorry, sir. Can you repeat the question, sir?
My question is, there are various things has been discussed already during the various parenteral injection in the form of intramuscular or intradermal or subcutaneous injection. Should we follow the safe injection practices?
Yes, sir. We need to follow, sir.
We should follow. Regarding the procedure, the solutions which are using, that is chlorhexidine 0.5% and 2.5%.
Yes,
there
sir.
are two types of solutions available in the market, and we know that 0.5% is for hand sanitization and 2.5% is for meant for the various procedures. Do you agree to it?
Yes, sir. Skin preparations. Yes, sir.
Okay. Thank you, madam. Thank you very much.
Thank you, sir. Thank you, sir.
Yeah, Dr. Naresh, you are clear with your questions, right?
Yes, very well clear.
Yeah,
Thank you very much.
Over to Dr. Dinakar. Can you take over, sir?
Yes, nice topics. Thank you, Raghu. Chaitali, as usual, superb.
Thank you, sir.
Amaresh, first time I'm hearing your talk. It's nice. Very authenticated, beautiful. Okay, very nice.
Thank you, sir.
Amaresh Patil,
sir.
There is one question for you.
Yes,
it is from my postgraduates.
Yes, sir.
Please, dear. But very tricky question.
Sure, sir.
Sir, baby is having congenital hip dislocation diagnosed. And we know that definitely baby is having a prop position. We have done the scanning. It is a severe congenital hip dislocation is there. It is 35, 36 weeker already. 36 weeker already.
Okay, sir.
Mother wants to give the Congro care. But during the Congro care, baby position, everybody knows. Both the hip is adducted. Hip flexion is necessary. And knee flexion is also necessary for the comfort of the baby and this. But here, congenital hip dislocation is there.
Yes, sir. So if the baby is, once the baby is stabilized, I would first send the baby to a pediatric orthopedician. To be frank, I would not encountered any of those cases. But this being a tricky situation, first I would like to address the congenital dislocation of hip first. And in the meantime, once it has been any public maneuver has been this harness has been put out, has been once the CDH has been treated, I would like to continue with the KMC. So if I would like to continue the KMC, in what are the portion the baby is comfortable with, sir? Hello.
Sir, video stuck again. Stuck sir video.
I think sir is
No problem.
Yes, sir. Yes.
Yeah, sorry. There is some issues. Sorry, Amaresh Patel. Sorry, please, dear friends. So hip dislocation, this is a situation. What is your opinion now?
Sir, first I would like to address that CDH issue first. I would like to treat it first and then continue with the KMC, because that's also a major issue. First, I would like to treat that, and once the baby is in comfortable position, I would like to continue with the KMC.
Because if you will put traveling
Yes, sir.
harness.
Yes, sir. So once the Pavlik harness is in place,
for 20 hours, then 2 hours.
Sir?
So it is very difficult to give KMC care. What we should do?
We can just comfort the mother, take her into confidence, talk to the mother more and more often, and tell her that the touch of the mother itself can soothe the baby, can relieve the pain, whatever the baby is going on. So that is most important, the confidence, boosting of the confidence of the mother and the family members, and communicating with them more frequently and adequately. That would boost the morale. That's what I feel, sir.
Yeah. Amaresh Patil, I'll come to you. Please, you should guide me. You are a very good counselor. Beautiful, dear.
Thank you, sir. Thank you.
I will come to you. I will give you the even fees also. Very good counselor.
Sir,
Chaitali is laughing like very hell. No, Chaitali, no laugh.
all the counseling part is all because of our great teachers, Dr. Guru Prasad sir and Dr. CRB sir, because of whom all.
Both are Guru Prasad's, what is that, students?
Sir,
very happy to hear.
Sir, I agree with Dr. Amaresh sir. Whatever clinical skills and counseling skills we have learnt is from our seniors, sir.
Teachers. Sir.
Yes, dear. Okay, one small thing for, I'll come back to you, Amaresh.
Sure, sir. Sure.
It's all like tricky, but it is very interesting for the people who are here.
Sure,
Just
sir.
that is the reason, dear.
It's a learning process for me also. I'll also be learning.
So, Chaitali, for you.
Yes, sir.
ICDT removal. During the procedure in the books, they are telling ICDT should be removed during the expiratory phase. But it is very difficult for me to remove during that phase. Sir, why so they are telling like that? Because ICDT just my PGs will pull out, but the air collection is not happened. But they are telling strictly to do that. What are you doing, dear? Please, Chaitali.
Sir, usually it is very difficult to follow the expiratory phase. What basically we do is we usually see for criteria like minimal chest drainage, clearing of the chest areas, clamp for at least 24 hours. If there are no respiratory instability for the child, if respiration is okay, child is breathing well, vitals are stable, then slowly remove it. As such, I think you have to answer the question, sir. I don't know about expiratory phase removal. We usually remove the sutures and pull it out, sir.
No,
Prior to removal, see to it that at least baby is comfortable with clamped ICD for at least 24 hours. That is very important. The air column should be totally stopped moving. Vitals of the baby is very important, and clearing of the pneumothorax. These are few of the criteria rather than keeping in mind in removal of expiratory phase. If these criteria are followed, I think we can do.
Yeah, go to the books, all the things are telling, but Even it's very difficult because in my unit, all PGs are only removing if it is there. It is difficult. I am just been asked in whatever I am asking, it is being asked in DM, PGI, Chandigarh, all. So that is the reason, dear. Okay, one small thing. Once again, Chaitali, please.
Yes,
Okay, are you ready?
yes, sir. I hope I'll be able to answer the question, sir.
No. So, sir, we know how to place UVC. Please, whenever I place, either it goes to the right hepatic or left hepatic, please guide me how to push UVC one at a shot to IVC junction. Please tell.
Usually, sir, the most commonest place during the catheterization we get itches for especially placing the UVC is at the level of the ductus venosus junction. If you feel any itches or difficulty in inserting at that time, you can slightly use other maneuvers like rotating the cannula and inserting. Not
Okay,
sure,
dear.
sir.
No. I just whoever there, just.
Sir, I think you can answer the question, sir.
No, dear. Small thing. It is. I don't know. Somebody is talking. Okay.
Can you mute
whenever you are placing the UVC.
Yes, sir.
Just remember. So tell your your helping staff or postgraduate or nurse. Push the right side of your.
Sir, kindly unmute, sir. Unmute, sir. Dinakar, sir, unmute, sir.
Sorry, Chaitali, I am sorry. Okay. See, when you are tell your assistant or nurse, when you are placing the UVC, when you enter the UVC in umbilical, just 1 to 2 or 3 centimeter, not more than that. Okay, when you are entered 3 centimeter, tell your assistant to push the costal angle. Means you know where is it? Where the ribs will end and
sir.
abdomen starts. Where ribs. Okay. That area, tell them to push towards the left side. How much to push to the left side is important. Just push it 3 to 4 centimeter. It is only subjective. Or maximum towards this side. Push it approximately. You push that UVC directly, it will enter. Because ductus venosus passage usually enters to the, because it is slightly turns towards the right side. That is the reason we land up into the right hepatic vein. So push the liver. So ductus venosus will become slightly straight. So it will easily enter to the UVC. UVC means IVC junction. But never keep your UVC in ductus venosus. You should pass the ductus venosus. You should go to the right hepatic vein juncture. After that juncture, where right atrium is there, that place you should keep, not ductus venosus. Okay, dear. One small thing to you. Please don't feel bad.
No,
okay,
sir.
We are all together with you.
No, sir. I learn from you, sir. No, sir.
Okay. Then you told in your talk, sir, PICC line, you have a double lumen. Which company provides PICC line double lumen? Because I never seen in my life.
Sorry, sir. It was a mistake. It was mainly UVC. For the UVC, I said for double lumens. It's single lumen PICC lines, sir.
Alva, sorry. I was so shocked, and I want to ask the company fellow, because if PICC line double lumen, if PICC line we need a double lumen, at least we need a 4 French.
Yes, sir. 4 French. Yes,
that is called a multi-cap.
Multi-cap. Yes, sir.
Central cap, because double lumen, triple lumen can come only with a 4 French. It won't come in 3 French or 2 French.
Yes, sir. Correct, sir. Yeah. Yes, it was my mistake.
Yeah. Mistake alla kana. Ayyo magne. If we fail, so come to the UVC. My postgraduate sometimes will cut the umbilical cord till the skin. Almost they do digging. They find something, but they won't find. So how can I do, sir? They're asking. Easy method. You know, can you tell me easy method? But I need to do UVC because I have to do partial saline exchange transfusion. How can I put, sir?
Sir, cutting, as you told, cut it at the level of the base is always very dangerous and it is very difficult to visualize, sir. At least half a centimeter of at the above the stump, if you cut it, and if it is a fresh cord, you can visualize it, sir. Cutting totally at the base sometimes might be difficult, or if the cord is totally shriveled. If it is something called a dry cord where it is very difficult to visualize, then sometimes we might create a false passage while digging. So it is always usually my analyzing of knowledge is umbilical veins lies, but if it is a shriveled cord, it always lies at the level of 9 to 12 o'clock position. You can visualize and put it, sir. Too much.
If they bugged it, they went to abdomen, still not possible, but they want to place UVs.
So they can go for a supraumbilical catheterization otherwise.
Yes, supra, how better you can tell my postgraduates, this is your UVC after supraumbilical, how better?
I didn't get you, sir.
No, you are showing your postgraduates, you have done the supraumbilical.
Yes.
Supraumbilical.
Yes, sir.
Okay, how
Yes,
better?
sir.
This is your UVC, how you will tell?
Ideally, it is always catheterizing through umbilical vein is preferred rather than supraumbilical. If really we want to do it, I usually, in my unit, I tell them to take the help of the pediatric surgeons and then do for the supraumbilical catheterizations, sir.
My pediatric surgeon is very good, very good, very good, very good. So, but he is not available.
I'm not sure, sir.
Here it is when you cut supraumbilical, put your incision vertically in that, recta diverge, wherever the muscle is not there.
Yes.
That exactly 12 o'clock position, recta diverge, whatever, where when the baby cries, it will like in this, where the two muscles will come, center gap will be there. I don't know, recta diverge or something like that. Okay.
Yes, sir.
Longitudinal cut you will give. When
Okay,
you will
sir.
cut the longitudinal subcutaneous, just you will open the subcutaneous, below the subcutaneous, whatever the things you are finding, please clamp it like this. Then you do horizontal cut. You will see very easily. You just blindly poke your catheter. It
Yes,
will
sir.
easily go UVC. In case if false tunneling will occur.
Yes,
It
sir.
will go either to persistent urachus,
Yes.
that vitreointestinal fistula, if it is
Yes,
there.
sir.
If it is not there, it won't go. Otherwise, persistent urachus, if it is there, it will go. Otherwise, it won't go.
Yes.
Unless we can go inside, we will only create persistent.
Yes.
Otherwise, it won't. So easily it will go, but very easy. Try, dear. Once it is very easy. Amele, one small thing. Sir,
Yes.
quick line I learned from Chaitali. Now I want to place. So my postgraduate is placed.
Yes, sir.
I told him, "Arey bhai, remove kar do. Remove it, please."
Yes,
But
sir.
while removing, half of the PIC line is gone inside. What he should do? Cardiac surgeon is not there. What he should do?
Yes,
How to
sir.
remove? He is nervous of medico-legal action. He is shivering.
Yes, sir. Actually, so this scenario had come in my mind, what to do in such scenarios, sir. So can I take the help of the book which I had referred, sir, to answer this question?
No. It is no helpline, no phone a friend, no option, no delete. Hey, joker. It's all
No,
humorous.
sir. No, humorous only, sir.
Then only it will be good.
So I think they have to go for again a pediatric surgery help and do the procedures and remove the PIC lines, sir.
Okay, now pediatric surgeon has come. He told us to take the X-ray. X-ray being taken, it is migrated into the liver. So what should a pediatric surgeon should do? This is one case. I'll tell you why, what happened later, what we did. So now what to do? Ultrasound also detected it is in somewhere in the liver. What to do?
I don't know, sir. I'm just practically answering. I'm not sure, sir. If baby is stable and if it is not
Very
causing...
good. Baby is kicking, very good, feeding, super. But only who has pulled that catheter, she is shivering. She has gone to bathroom 5 times. Okay.
So I think if the baby is stable and hemodynamically stable, not causing any problem, we can leave it. I'm not sure, sir. But the parents are very Google masters, and they are complaining nature. So that now everybody started shivering. Hospital admin came to know. Hospital admin told you will dance. What should I do now? Surgical procedures. I'm not sure, sir.
Okay. Now later I will tell you. Now it has entered into the heart. What to do? Let it be there. Still, please be there. It is let it be there. This is second scenario. It entered into the heart. Happily, it is there in the right atrium. Right atrium. It is happily sitting. We can see in the echo. There is somewhere it is large. What should I do?
I'm not sure, sir. It has to be removed, probably.
Okay, so I'll tell you both the scenarios.
Yes, sir,
why
definitely.
I am telling, we are all friends. So
yes, sir, because we need to know this, sir, because sometimes this happens very commonly while pulling out. The remnants might remain, so we need to know what to do for such situations, sir. Yes, sir.
So case number 1, please try not to use PICC line if it is old. If it is fresh, because expiry date is there. If it is 1 month, 2 months, like that is there. Breakage chances, length is there, breakage chances are more common. Try to use a fresh one. That integrity will be sometimes lost. Number 1 scenario. Number 2, here it has entered into the liver, happily sitting somewhere in the either hepatic vein, right or left. If it is sitting, if the baby is fine, don't call and cut the liver, just leave it somewhere in between the 2 layers that will have like this, and it will have a granuloma. If it is there permanently, it will stay, it won't cause anything. Number 1, because it is a neonate. Number 2, don't try to not remove, because suppose if the vascular surgeon is telling, leave it. If he can put it and remove it, let him do it on his own. But try, because of this, don't subject the baby for cutting the liver and other things. It won't cause anything. Permanently, it will go and it will sit on that, and it will have some epithelium. Nothing will happen.
Okay.
But just your luck also should be good. Number 1. Number 2, third scenario, if it sits in the heart,
yes, sir.
same thing will happen. Same thing will happen. You need not worry. What will happen? If the baby is fine, doing well, don't subject the baby for removal it. Because there are 2 things. If it dislodges somewhere, it might go to the even aorta and brain or somewhere, but we don't know. If it is sitting, please tell them it is there. You please come like this. Nothing. There is something, mass is there. Because nobody can diagnose there is something either in a cardiac MRI or something, but they can see in cardiac MRI, you know, and it, because after some time, everything will become like a mass, like a, when you will put UVC, thrombus will form sometimes.
Yes, sir.
So it will form, leave it, because it will also embed in endocardium and layer will form.
Yes, sir.
In case if they can go and remove it, like, cubital fossa and stunting, if they can, how the adult, they will do the cubital fossa and do the stunting. That is now, previously they used to put from the length and all those things. So they can, interventional cardiologist can remove. If they don't remove, if it is small, if everything, leave it. This is the things. Okay. Why I told you is, this is all the subjective, every day we do face it.
Definitely, sir. Yes, sir.
You both speakers are excellent. Really nice topic. Hats off to you people.
Thank you, sir.
Thank you, sir. Thank you, sir. On Guru Purnima Day, I learned lots of things from you, sir. Thank you, sir.
From you too. Both.
Thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.
Prashant, over to you, boss.
Yes, sir. Thank you very much, sir. And I would like to wish happy Guru Purnima and our special wish to Dr. Dinakar, sir. and because the entire Karnataka and entire India, we are all big fan of your teaching, and definitely we would like to dissipate the passion which you
My
exhibit.
Guru, all the people who are seniors to me, once again, happy Guru Purnima to everybody. I learned everything from you people. Let it be like this only. All this together we will work, boss. Please. Thank you, Chaitali. Thank you, everybody.
I would like to wish all the teachers of all the medical colleges, private practitioners, and all the doctors who indulge in teaching and who have got passion of teaching. Please continue that. It's something very precious. Sharing of knowledge is very divine, and it is like doing a good deeds. Please continue doing that. Please teach whatever you know. It is not that to tell whatever we know. If you tell that, more than enough, and that is what we have learned from our teachers. So on this occasion, we would like to wish NNF Karnataka, all the seniors, all the participants, and all the teachers happy Guru Purnima. Have a nice Sunday. Have a nice evening. Bye.
Thank you, sir.
Thank you, sir.
Thank you. Bye, sir.